Good morning, everyone. Good morning. Good morning and welcome. Welcome those of you in the room. Welcome those of you who are joining us virtually to the 2023 Loyola Health Equity Quest. It's a summit that Matter and Loyola University Chicago are putting together that's focused on the intersection of climate change and health equity. I'm Stephen Collins. I'm the CEO of Matter. We are a healthcare technology incubator that's built on a belief that collaboration is the best way to innovate in healthcare with a mission to accelerate the pace of change of healthcare. We functionally do three things in service of our mission. We incubate startup companies. We run an incubator. We've worked with now about 850 companies since we launched in 2015. Collectively, they have raised about $5 billion to fuel their growth, and we work with them across the full range of building their businesses, from just getting started all the way to scaling up in the market. The second thing is we help large established organizations innovate more effectively to better harness innovation to improve health and the business of healthcare. We run accelerators. We have insights capabilities and training products, and we work with life sciences companies and insurance companies and health systems and technology companies and associations and others that want to both better harness their internal innovators and also reach out to the ecosystem of entrepreneurs that exists outside their walls to better collaborate to advance solutions that can accelerate the pace of change of healthcare. And third, we are a nexus for those who are passionate about healthcare innovation and healthcare transformation and health. And we put on a lot of events. We put together forums and summits and programs that are designed to educate and inspire people who around a variety of topics focused on healthcare innovation, including what we're doing today with our partner, Loyola University of Chicago. This is our second year working with the university on this particular topic. Last year, we took a different approach. We asked entrepreneurs and innovators for ideas on addressing the effects of climate change on health equity and incorporating sustainable products and processes and services into healthcare delivery. We had, at our final pitch event that we did a year ago, we heard from 8 novel entrepreneurs who were innovating in this area, and we gave them both cash and mentorship to pursue the development of their solutions. Today, we are bringing executives and entrepreneurs and investors and policymakers and leaders from across the industry together to discuss the challenges and the opportunities in this space. Over the course of the day, you'll hear from some really amazing speakers. We have speakers from the White House Council on Environmental Quality, the Illinois Department of Public Health, Cigna, the University of Illinois, Loyola University Chicago, of course, and many others. The goal is to promote learning and collaboration among all of you here in the room, all of you joining us virtually, to accelerate the pace at which we can reduce health inequities that are caused by climate change, particularly with a focus on vulnerable populations. Our goal is for you to leave this summit feeling motivated to work together as an ecosystem to drive real change. Thank you to the team from Loyola, who's been truly delightful to work with for the last 2 years, and with whom we've worked on the planning and the oversight and execution of this program. Dean Elaine Morato, who is right here, thank you. Mike Bloom, who I saw earlier, Matt Anderson, Merle Thomas, Jennifer Sloan, all from the Parkinson School of Health Sciences and Public Health at the Loyola University of Chicago. So before we dive into the great discussions, we have a special guest, and it's my pleasure to introduce the president of Loyola University Chicago, Mark Reed, who's going to say a few words about the importance of this topic to Loyola. Dr. Reed was appointed to his position as Loyola's president last year after 7 years leading St. Joseph's University in Philadelphia. He lectures in both the business school and the education school. And he is clearly focused on the right things because, as evidenced by his presence here today, thank you so much, Dr. Reed, for being part of this journey, for working with us and focusing on this important topic.
Good morning, and trust me, I'll be brief. I'm just the warm-up act. There are many other people who have many more important things to say today than I'm going to. But on behalf of Loyola University Chicago, it really is my privilege and pleasure to welcome you to the 2023 Health Equity Quest. And thank you to our partners at Matter for hosting this event, along with our partners, the Geneva Sustainability Center of the International Hospital Federation, Healthcare Council of Chicago, the NIH-funded Institute for Translational Medicine, co-led by the University of Chicago and Rush University, and the Women's Health Initiative, Inc. I'd also like to recognize the contributions of other Loyola partners in developing this summit. The Baumhart Center for Social Enterprise and Responsibility out of our Quinlan School of Business, the Institute for Racial Justice, the School of Environmental Sustainability, and the Office of Environmental Sustainability. And a very special welcome and thank you to our keynote speaker today, Dr. Jalon White Newsom, Federal Chief Environmental Justice Officer for the White House Council on Environmental Quality. Thank you for being here. The Health Equity Quest is an annual signature event now of Loyola University Chicago's Parkinson School of Health Sciences and Public Health, and it is made possible with support from the endowed Parkinson Innovation Fund. And we're eternally grateful to Bob and Betty Parkinson for their generosity and their vision in supporting and establishing and helping to establish the school at Loyola. Our goal is to build cross-sector partnerships that advance health equity. And I am so glad to see so many of our partners represented here this morning because we all are all about collaboration and about convening expertise. Loyola is known for a distinctive Jesuit Catholic commitment to the care of the whole person and to whole communities, and to find ways to make quality, compassionate healthcare accessible for all. Loyola brings together disciplines and perspectives. Medical scientists, environmental scientists, social scientists, policy wonks, business experts, urban planners, and more, to leverage results-driven progress in this space. And these collaborations are an intrinsic part of our calling as a Jesuit institution to go to the frontiers of education, research, and practice to accompany and to serve the marginalized and the underserved. Loyola has challenged itself to prioritize transdisciplinary collaborations in education and research to address community health disparities and broader issues of health equity. The Parkinson School of Health Sciences and Public Health was born of that intention explicitly, and Parkinson faculty, staff, and students work extensively with other schools and disciplines across Loyola University and with partners around the region and the globe. The Health Equity Quest is an example of the ways that Loyola's Jesuit mission brings together leaders from many fields and perspectives in addressing urgent issues. And each year's quest posits a different theme. And this year we convene thought leaders and innovators from diverse sectors across the nation to collaborate on making the U.S. healthcare system more sustainable and equitable, and to identify and address health inequities deepened by climate change. And this year's summit represents a trajectory of collaboration. It builds upon work with Loyola School of Environmental Sustainability at last year's Climate Change Conference, and climate justice was also the focus of the 2022 Health Equity Quest Incubator Challenge, and of an invited panel from Loyola at the American College of Healthcare Executives annual meeting this year. Now, care for our world is among Loyola University's strategic priorities, driving its mission of education, research, and service. And many of you are engaged directly in this work already, and I thank you for it. But in any case, by your presence here this morning, you are a part of this ongoing collaboration. And so It truly is my pleasure and privilege as president and on behalf of Loyola and on behalf of future generations who will benefit from your work today to say thank you and to wish you energizing and productive discussions. How could they not be? This is pretty cool space. And now it's my pleasure to introduce Elaine Murato, Dean of the Parkinson School of Health Sciences and Public Health, who will offer some reflections on our program and our aspirations for today. Thank you very much.
Thank you, Stephen and President Reed. I get the pleasure of serving as your MC for the day as we go through our quest of nested discussions, inspiration with our keynote, and as you heard, how do we take what we hear today and mobilize for continued action? It's a quest. We won't get to that journey today, but we are here to mobilize around that quest together. So I wanted to, I get to set up the what is the problem need? Why are we here? And I know you all know why we're here because you're here. But I think it's good to remind ourselves of the urgency of the situation. You know, I pulled this from the World Health Organization. You know, we've just come out or still recovering from a global pandemic. So it's hard to put other global health issues into that context, but to know that climate change is the single biggest health threat facing humanity right now. It does not take much to look out our windows and see the heat waves, the fires, the floods, et cetera, that are happening as a signal of what's going on in the world around us. That picture that was part of the electronic information that you received around the quest is real. It's not a theoretical. That's a picture of Chicago last June when all of the forest fires from dryness and drought in Canada and that particulate matter made its way here to Chicago, in which at that time we had, as they said, it was reported, the worst air quality in the world. And so it will affect us in ways that we haven't seen yet. Not just is it a 500-year flood, but that is going to be becoming more and more increasing. So we are compelled to act. And why are we looking at it as a healthcare delivery? Well, that is if you look at the health sector collectively, how we deliver care, as you look at the supply chain of producing care and products for care, and you consider us as a country, we would be the 5th largest greenhouse gas emitter on the planet. So there's a lot of work to do if we believe that CO2 is a key contributor to what's happening in global warming. What are we doing as a health sector to contribute to a solution toward that problem? And as President Reed said, why Loyola? Why are we compelled to act? Well, one of our key tenets is that we are called, as a Jesuit Catholic institution, to collaborate in the care of our common home in Mother Earth. And Pope Francis has been a tremendous advocate on behalf of the environment and climate change. Here are some words that come from his statement just this last month, essentially admonishing us for not doing more faster. And a call to action that we urgently need to efficiently and flexibly implement, not just talk about goals and proposals, but translate it into action. And that's what we hope today's set of nested discussions might compel you to think about. How do we move from ideas to action? That's sustainable action. The Parkinson School is a school of health sciences and public health, and this gives us an opportunity to think of it in a systems base. We're not just a silo of public health or a silo of healthcare delivery, but how do we think about this in the total picture, including the social determinants of health? And that's why I'm so delighted to have peers of mine from Loyola, from our School of Environment and Sustainability, our business school, and from our Institute of Racial Justice, who all care about this, and the fact that we believe very strongly that the highest attainable standard of health is a fundamental right of every human being. It's our calling why health equity is important. But we're also a newer school. We're coming up on our 5 years, and we like to think of ourselves as, I'm a founding dean, just like many founders that are here. And so how do we bring an entrepreneur mindset? How do we get inspired with the environment that we're in here at Matter to think maybe a little differently? And so the next few slides are sort of my challenge to you. You'll hear this as a running theme, and we'll come back to this at the end around what did we take away from today. And that is to think about this as an entrepreneur word and the insights that we get so that we are reducing health equities and improving population health, but bringing with it a lens of collaboration and where do we go next. And this really here, we know that we have some partners here who are deep expert. This is their life calling. There was a wonderful session just a couple of months ago at UIC on this topic. It really is almost like a tag team running around the track. How do we hand the batons to one another so that we keep running and not letting that baton drop? And we can only do it with partnership. And we are so excited that this isn't just an academic conference. It isn't just an entrepreneur incubator conference. We have government, we have non-government, we have health sector, we have students, we have the next generation that are very inspired to make a difference as they go forth in their lives. So, what are the nested conversations and how are we thinking about them conceptually? We will hear a panel that talks about what can we be doing to reduce healthcare's carbon footprint. As I said, we are the fifth largest global emitter. We're going to have a discussion around it's not just the healthcare delivery and the facilities, but it's the inequities that climate change are also contributing to in the people that our healthcare systems serve. But our healthcare systems serve and operate within communities, and it's equally important that we consider issues of building resilient communities so that collectively we can respond together. And we'll be starting with an outside in, so our first panel starting with building the resilient communities. And so I challenge you to listen to it the way we teach about it with entrepreneurs and startups, right? What is the value proposition of what we're talking about? Why should someone adopt this action right now? In higher ed and academics, we're trained to write about the societal significance. What is the prevalence? How many people have this? How many people die from this? How many people go to the hospital from this? And that is motivating. But we are all individuals and we work within groups that have other competing demands. And so my challenge is, how do we listen to the insights of those that are speaking so that we pull out what are the most important jobs to be done in the sectors in which we operate, in which we might think of immediate solutions that are also benefiting the climate change goals that we have. What are the pains that health systems are dealing with right now that there might be win-win opportunities? Before the panel, the discussion we were talking, the young generation is demanding this. And so when they graduate medical school and they say, where do I want to work? They're looking for healthcare systems, hospital settings that care about this important problem too. And so now a pain is, how do I attract and retain top talent? I need to be also responding to environment. That's what we want to be listening for. How do we identify win-wins? And that it's really a quest. And so you teach this as you go from startup mode to sustaining business model mode. What is the problem? We're going to hear a lot about the problem. What are opportunities for solution? Where is there really good fit such that we can test it out and try it and get a beachhead market where there's some traction of people willing to pilot it? That's a product market fit. That we get the evidence such that it's scalable. But we also know that we operate in a society in which we have to pay for things. And so what's the business model that's going to allow us to sustain the work? That it's not just projects that we do within some grant funding, but rather it's sustainable solutions. And for that, we've got to listen to really what is the business value out of that. And that we hope that we are inspired today, so we have ideas that might help us mobilize for faster translation. It's not theoretical. In fact, a lot of people are very concerned, and there is environmental anxiety. And we're called to make a difference in this, and there is urgency for us to act. And so we hope that this is not just another talking head time together, but rather that there's energy coming out of it. And so that's our hope and aspiration for today. So with that, I am delighted that we have Dr. Jalon White-Newsome with us here in Chicago on her way from DC as the first, not just the first federal chief environmental justice officer with the White House Council of Environmental Quality. And some of the things, if you're interested, there are QR codes as you go along if you want to refresh on the total biography of our speakers today. But I just want to call out a couple of, an item that you may not be aware of the ambitious agenda that's going on right now with the president's administration. You know, Dr. White-Newsome has issued an environmental justice executive order and established the first ever environmental justice scorecard. Because as we know in healthcare, what you measure gets done. And so with that, I am delighted to hear how we might bridge the gap and do better in climate justice and health equity. Please join me.
I think I might. Good morning. Good morning. Oh, you can do better than that. Good morning. Good morning. All right, all right. Can they hear me virtually before I start talking? Okay. Awesome, awesome. So first of all, thanks so much for the kind introduction and really, I think, setting the foundation for what I hope will be a series of great conversations. And I feel like we are all on a continuous journey. We are never there, but this is one step in that journey. So congratulations to each of the partners and all of you for taking the time to make this space. All right, I'm going to project. So I learned several years ago from a dear mentor of mine that it's important to start out by recognizing the place where we are. So we are sitting on the original lands of the Ojibwe and the Potawatomi peoples. And I say that because as we talk about people and resources and climate, it's important to recognize that sometimes the folks before us did a better job of taking care of this thing that we call Mother Earth. So I think it's important as we think about solutions and you're on this quest for health equity that we give into kind of the wisdom of our ancestors and bring it into the solution sets that we're trying to talk about here. And also being in Chicago, have to recognize the deep history of advocacy and justice around health and environment for some of our ancestors that are now in heaven now, but again, that I learned from and gained wisdom from and want to just honor them, their work, even though they are not here with us today. So I will say very quickly, I am a very proud native Detroiter, but I have so much love for Chicago. Not only the Taste Festival, which I hope it still happens, my deep dish pizza that gave me my freshman 15 and 20, but also I have family across this city in many different parts. My great uncle, I spent a lot of time in Bronzeville, and he just taught me so much deep history and all the great folks that came from that community. And then, of course, I was at Northwestern University up the road and had an opportunity to spend a lot of time in the city. And so, again, as I think about just this place and the potential and the power of the people in this room and outside of this room and our virtual folks, I am so delighted and heartened to be here, and just thank you for the invitation. So, again, as mentioned in the very kind introduction, I have the opportunity to be the first and hopefully not the last Federal Chief Environmental Justice Officer for the White House Council on Environmental Quality. Now I'm going to start and I'm going to ask this question. How many of you all know what the Council on Environmental Quality is? That's usually the reception I get, so we're going to start there. The Council on Environmental Quality, or CEQ, is one of the policy councils in the Executive Office of the President. So you've probably heard of the National Security Council and the Domestic Policy Council. We're one of those. And so basically our job at CEQ is to do a couple of things. Our role is to coordinate the federal government's efforts to improve, preserve, and protect public health and the environment. That's a major mission. And so part of how we do that is working with our agency partners, with our other folks in the executive office to make that real. And what's cool is that this is the first administration that has created an Office of Environmental Justice, because we never had that before. And so now as we talk about this mission of improving public health and the environment, environmental justice is a key part of that. So my role, again, is to help President Biden execute this ambitious environmental justice agenda, which I'm going to share a little bit about with you today. So I am blessed to come from a family of public servants. So particularly my mom taught me very early on that this life is not about you, but it's about serving others. And when I talk about serving others, it's really making those that have been invisible visible. So when we talk about health equity, when we talk about environmental injustice, it's unfortunately that we see our black and brown folks, our indigenous folks, our low-income folks that oftentimes remain invisible in society. And so when I think about my work and research of over a decade ago at this intersection of climate change, environmental justice, and health, that's exactly what I set out to do. So I had an opportunity to study at the University of Michigan School of Public Health, and my research was focused at this intersection because, as most of you probably know in this room, that intersection is critical. And so I just happened to be in Paris during one of the worst heat waves in 2003. I just happened to be there. I also just happened to be in Chicago during 1995's heat wave, which again is the infamous heat wave that many of us as public health practitioners have studied and learned from. And again, that is a heat wave that took so many lives. When we talk about our black and brown elders, folks in high rises, I mean, lives that, again, don't need to be, like, we shouldn't be losing any lives to heat, right? So when you think about the impacts of extreme heat, that is something that has been top of mind for me for a long time, because we know that 1 degree can be the difference between life and death. So I witnessed my grandparents and other beloved elders, again, in the community that I grew up in Detroit. And again, I saw them sitting in their homes, their health jeopardized by just sitting in their homes, which is supposed to be a safe space, because their homes were unweatherized. They couldn't afford the electricity bill, so didn't want to turn on the AC. And again, you talk about urban heat islands, or the fact that folks live in these concrete jungles. All of these things contributed to heightened risk. So again, when you talk about heat stress and heat-related deaths, that's what we were seeing in Detroit and many cities across this country. And so my work was driven not only because at that time I was the caregiver for my grandparents, but because there was a gap in the literature, there was a gap in the action. And so when you think about research and the importance of research, it should be informing action and informing things that are going to help people live safer and healthier lives. And so again, the literature and acknowledgement of heat as a threat has grown since the decades when I did my research a long time ago, but we still have more things to learn because people are still dying to heat unnecessarily. So we know that the communities that suffer the most are those that are underinvested, those that are dealing with the multiple issues, the cumulative impacts of everything, because no one lives in a bubble. We know that tree canopy and building up green spaces is one of the solution sets. But again, with climate change getting worse, we have to act. And so when I think about the importance of what you all do and the power that you hold, when I think about this health equity quest, it is very much inextricably linked to achieving environmental justice, and we can't do one without the other. So again, that's why I am so honored to work for a president that has made this historic whole of government approach to advancing environmental justice. So when you think about this belief that everybody, regardless of what you look like, race, ethnicity, how much you make at the end of the year, what zip code you live in, deserves to have clean air, clean water, to live in a healthy environment. And President Biden recognizes that. For far too long, that has been the reality of so many communities across this country. And so when I think about the vision of my environmental justice office, it's basically making sure that the fabric and foundation of our White House and our federal agencies embrace environmental justice as a part of how they do what they do, that it is never an afterthought. And the way that we will achieve that vision is through 3 main goals. First, we got to reduce burdens and harm on those communities that are feeling the most, plain and simple. Secondly, we got to make sure that the investments that we're talking about, as you see, I'm not keeping up with my slides because I'm just talking. We got to make sure, number two, that the investments reach those communities that need it the most. So we got a lot of money going out. And third, we got to make sure that we institutionalize the stuff that works. So again, as we have these political shifts, that the focus and the work on environmental justice does not dissipate. So during the president's first week in office, he signed Executive Order 14008, tackling the climate crisis at home and abroad. And what was cool about that is that it launched the most ambitious environmental justice agenda and climate agenda ever. And there was a bunch of initiatives. I encourage you to Google it and look at the language in 14008. But there's one initiative that I want to raise up, which is our Justice 40 initiative. Now, the Justice 40 initiative aims to direct, and this is important, 40% of the overall benefits of certain federal investments in climate change, clean energy, safe and affordable housing, water and wastewater infrastructure, all those investments to what we call disadvantaged communities, right? And so when you think about the huge laws that have passed, the Bipartisan Infrastructure Law or bill, or the Inflation Reduction Act, the IRA, these are monies that are going to be focused, again, through this Justice 40 initiative in what we're calling disadvantaged communities. And so it's important to know that this is not just an initiative around this pot of money. It is about how we are fundamentally reshaping how the government operates. So the fact that we have agencies rewiring how they do what they do to make sure that these dollars and cents get to the communities that deserve it. And so right now we have over 470 programs that are being reshaped and revisioned across our federal agencies, meaning the Environmental Protection Agency, Department of Energy, all these other folks that are very important to, again, reducing the carbon footprint of the healthcare sector. And so when you think about what that really means and how that can benefit communities, I just want to recall a conversation one of our staff had with the mayor of Norfolk, Virginia. And basically, in a nutshell, you have communities that are set up to create the applications to go after these funds from the federal government. They have their cost-benefit analysis, they have a staff, they have all this great stuff, they've gotten money before, relationship. But then you have these communities that are not set up, don't have access, don't have staff, don't have the capacity to do a cost-benefit analysis and end up losing out. Well, because of the Justice 40 initiative, our agencies are flipping the script to make sure that communities that are disadvantaged have that same opportunity. And I'm excited to say that in the particular city of Norfolk, the communities that, again, were once unavailable and inaccessible and not able to get those funds are now being able to access those funds with additional support and help. And that's just one small example, but that's a big deal, right? Because we, again, are one step at a time in this longer journey to achieve health equity. So because of the Justice 40 initiative, we are changing structure. Like I said, it is not just about dollars and cents. It's about how do we change structure for good. And when I think about, again, right here in Chicago, just last week, the EPA, the Environmental Protection Agency, announced $336 million for water infrastructure right here in the city to change out over 30,000 lead pipes. And again, we know the impacts of lead on our babies. I'm from Detroit. Flint is up the street. And so these are just some pieces of the Justice 40 initiative that I want you to be aware of and I want you to follow because they can have tangible impacts in your community. But I also got to give some props to Cook County right here. The Board of Commissioners developed its own local effort sparked by our federal Justice 40 initiative called the Cook County Justice 40 Infrastructure Fund Initiative. And so what's cool about that is that this resolution by the county affirms their commitment to advancing the principles of the Justice 40 initiative and all of the things that they are doing to apply for grants to address climate and health equity. So that is exciting and what we want to see, how the Justice 40 initiative at the federal level is trickling down and really, I would say, influencing state and local action. But you might say, okay, this all sounds good, Yolanda, that's great and fine, but how do you know where these disadvantaged communities are? Well, I'm glad you asked, even if you didn't. So the question I always get is, where do you find them? And I will tell you, it's so interesting to me, again, as a researcher, and when you have these expectations of folks, whether it is our federal agency partners or maybe across the health sector, sometimes folks are like, where do we find the people that need the help? Well, we have a climate and economic justice screening tool, and I'm going to remember to advance my slides. So I encourage you to Google Climate and Economic Justice Screening Tool. You know, we got acronyms in government, better known as the CJUS. What this tool does, it is a geospatial mapping tool that basically identifies communities that meet certain burdens around thresholds of certain social, climate, and environmental indicators. And what you can do, anybody, as well as our federal agencies, is figure out what your neighborhood or community, if you're identified as a disadvantaged community, and take advantage of that. This is how our federal agencies, they have to use this tool to, again, prioritize where their resources are flowing. So again, this is a tool, it is free, it is publicly available, and our federal agencies have to use it. This is how we identify those communities where we want to prioritize and focus. But what's also important to know is that this tool we did not develop in a silo. We sought the advice and wisdom of communities across this country to tell us really how this tool can better reflect the realities that people are living every day. So again, this is a tool that we will update annually. And so we are also always welcome for feedback, what data is missing or what data should be there. So again, I encourage you to Google it, look it up, figure it out, where your community sits, and also what communities you could be helpful. So the other thing of interest, and I'll move off the CJUS, is that, again, in this tool, because I'm talking to a health audience, I think it's important, we have a couple of health burdens that are measured in this tool. So one is asthma, diabetes, heart disease, and low life expectancy. And we know there are many others, but of course, for anybody that has developed a tool, you know that there has to be some quality control. We have to have the right data at the right time, at the right level. So again, if there are data sets that you think should be in this tool, please reach out to us and we will be open to that conversation. So across the country, again, as we know, Americans, unfortunately, are experiencing continuous climate disasters. I think in the first 8 months of this year, there's been 23 separate billion-dollar weather and climate disasters, more than any other year on record, which is a problem. And so when we think about these longer-term impacts of climate change, whether it be sea level rise or hotter average temperatures, changes in precipitation, it is affecting everybody. And so in September, I'm happy to share, if you didn't know already, the Biden administration announced a national climate resilience framework. And what I will say is one of the 6 objectives of this framework is to help communities become not only more resilient, but also more safe, healthy, and economically strong. So this objective, of course, involves each of you in this room, and it's our opportunity to, again, enhance the resilience of our nation's healthcare system, particularly when we think about safety net institutions. So again, we know that extreme weather events, again, if you haven't experienced one, I hope you never, but personally, I have and my family has, so it is nothing to play with. But we know that as we continue to experience these events, again, the allocation of energy resources, the disruptions of services, particularly healthcare services, is critical, particularly to those folks that rely on it, right? So I want to just share with you a couple of things that give me hope, and I need hope every day. But one, FEMA made a $1.8 billion, and that's billion with a B, available under 2 Justice 40 grants designed to help communities increase their resilience and the impacts of climate change. So one was through their Building Resilient Infrastructure and Communities annual grant program, acronym BRIC, B-R-I-C, and that is making $1 billion available for projects to, again, beef up community resilience. There's also a flood mitigation assistance program, again, that is making $800 million available to communities to deal with flood mitigation. And both of these grant opportunities, again, these are just examples, are open until February of 2024. So we encourage you again to see if these programs and others can make a difference in your community. So the National Climate Resilience Framework is, again, one way that this administration is committed to advancing environmental justice across the federal government. But also, as was pointed out earlier, I cannot not be up here and say that the president signing the newest executive order on environmental justice, EO 14096. You know, it's a lot of numbers. Revitalizing our nation's commitment to environmental justice for all is something that he signed this past April, which is a big deal. And it's a lot of stuff. I encourage you again to Google it and read it. It's important. But I'm going to just highlight a couple of three things for this audience. One, it directs agencies to consider measuring and addressing disproportionate and adverse environmental and health impacts, particularly cumulative impacts of pollution on communities. So that is something that we are tagging agencies to do. Secondly, it directs agencies to identify those science and health and data gaps, again, to drive health equity. That is something that agencies have to do. And last but not least, it's directing agencies to make information accessible to people, right? To regular folks. And so again, there's a whole bunch more in that EO. I encourage you to look at it because it has, again, some guidance to federal agencies to make, again, health a priority. So I also want to highlight very quickly an announcement by our friends at Health and Human Services that might be of interest to you. So the National Institutes of Health, NIH, created this Common Fund Community Partnerships to Advance Science for Society, another acronym, COMPASS. It is the first of its kind funding for research, and it's designed to study ways and underlying structural factors within communities that affect health and access to healthy food and employment and transportation. Again, this common fund in the COMPASS program awarded approximately $171 million over 5 years to 25 community organizations. So again, check that out, get familiar, that's another opportunity. So in a nutshell, I would tell you, we have a lot going on to try and advance all these objectives around environmental justice and health and equity, and I tell you, it is super duper encouraging and overwhelming at the same time. But what I will say, and in my hopes of making it real for you in this audience, and I want to leave you with maybe 3 things that you can do to help advance our ambitious environmental justice and health agenda. So 1, shed the light, 2, share your success, and 3, stay connected. So I'm going to start with shed the light. Really simple. Don't let the invisible stay invisible. Open your eyes, look around your community, lift up and shed the light on issues that just aren't right. Elevate the issues that communities are dealing with that, again, is something that you want to wake up and deal with, right? So make sure that you are looking around and noticing what are the things that are affecting your community and taking the time to listen to those communities that are being impacted day to day. So I encourage you to shed the light. Secondly, I encourage you to share your skills. Now, you know, as experts in healthcare and health equity and academics and a whole bunch of folks in this room, in the virtual room, I know you have skills and talents that can help communities across this country access some of these billions of dollars that are out there. Even if it's just helping create a grant, helping identify those resources, getting technical assistance, whatever. I encourage you to reach out and connect with a community organization, again, that you work with, or maybe this is a chance to make a new friend, like I tell my daughters, and be supportive, share your skills, because that is still needed. Now, we are doing what we can at the federal government level to provide technical assistance and resources, but we can't do it all, right? So we need you to help share your skills. The last thing, I encourage you to stay connected. So about a year ago when we started this virtual newsletter called the EJ Connector. The goal was to make sure people were aware of funding opportunities and what we were doing in the White House related to environmental justice and our federal agency partners. Now, again, for you tech-savvy folks, there's a QR code there, and hopefully it'll work. If not, and you're old school like me, you can send a note to ej@ceq.eop.gov. Again, ej@ceq.eop.gov. Sign up for our virtual newsletter. It comes out every month, and you can stay up to date and connected. So if you are still awake, I am going to close very quickly. I so believe, and I don't know all of you in this room, that each of you are such an important part of this incredible ecosystem of leaders that I think are really working to make a difference, not only in our planet, but in the future. And so your role as health leaders puts you on the front line in many ways. and policy decisions, conversations, practices that can actually build healthier and stronger communities. So again, I hope that each of you will leave here inspired. I hope that you have a better understanding of all the stuff, some of the stuff that's happening in DC that you might not hear on the news, but I think deserves as much play. And I want to thank you again for each of your leadership as we try and build a legacy that we want to leave that encompasses, again, this promise of justice and equity and health for all people, because we all deserve it. So thank you so much for your time.
Thank you, Dr. White-Newsom, for being here, for your remarks. I have a lot of questions for you, but more interestingly are the questions that are going to come from the audience, both in the room and virtually. If you go to matter.socialqa.com, K, is that right? K, right? Yes, great. Matter.socialqa.com. You can ask questions. I have an iPad. I will filter them. But I want to get started with a just sort of general perspective. You know, we're in healthcare. Like, that's all we think about every day, all day long. And from an environmental perspective, there's sort of two lenses that we can look at. One is something that Dean Morato has said a number of times, which is that, you know, healthcare is a significant contributor to environmental degradation. You know, through the work, through health systems, through pharmaceutical companies, through, you know, it's a big industry that contributes to the challenges. At the same time, it is also an industry that helps solve the problems because it's on the front lines of treating the impacts of the environmental challenges and the fires. I mean, you mentioned asthma, and you mentioned diabetes, and you mentioned all these things that are caused or exacerbated by climate change. So when you're thinking about your work in the White House and how you think about the healthcare industry, are you working on both ends of that spectrum? Are there things that the healthcare industry should be thinking about from their own operations that you're involved with? Are you actively involved in supporting the healthcare industry's work for the interventions it needs to effectively provide because of climate change? That might be a lot, but that's I'll toss that over to you. Go.
I'm like, oh, that's a big question. I try and keep it real. So first of all, again, thanks for the question and the opportunity. You know, what I would say is, you know, the healthcare industry is critical. And I think there are so many industries out there that are like producing stuff that we need as humans to survive and do, but also have some detrimental effects that, you know, those kind of unintentional consequences that we have to deal with. And so I think what's important for any industry, and I'm a chemical engineer by training, so I spent time in the chemical industry and saw the impacts of that industry, is that you all are in the inside. And so what's most important is, again, we know it's this challenge, right? Like good versus bad, but how do you make the bad better? So what are the ways, the tangible ways that each of you can go back into your places of work and begin to ask the questions around justice, around how you reduce impact? And that's what's most important. So I'm a firm believer that we can always do better. We can, you know, maybe reduce, I think you said the 5th largest emitter. You know, we can make a difference there, but you have to continue to ask the right questions. So what are the tangible things that I can do in my position, whether you work in policy, whether you work within a hospital, whether you're responsible for managing the hazardous waste? Like, what are those questions that we need to ask that will get us to a place where this industry, and we can say, hopefully years from now, that, man, we actually made a difference. And so we are helping save lives every day, but we're also looking at the bigger picture and our bigger footprint. And so to me, that is what's so important, is that we begin to ask ourselves those questions. And I would say, you know, we have and work very closely with all of our agency partners. So CEQ, the Council on Environmental Quality, our role is to, again, have this influence over the White House and our federal agency partners. One of our partners that are part of our White House Environmental Justice Interagency Council, which we call our IAC, is of course Health and Human Services. So again, they have made environmental justice a part of their mission, both on the healthcare delivery side and even what I talked about in some of the grant opportunities to really build, again, resilience within communities. And so there are probably things they're doing that I don't know, but I will know that just underscore that environmental justice is a key part of what HHS is doing. We work very closely with them and some of our other partners that are very much connected to the, I would say, the emissions and the other pieces of the healthcare sector that are driving the changes in climate that we don't want to see.
Is there a health system or even a company outside of the healthcare industry that you've seen or you point to and you're like, wow, that is an example where the people who work for that company or that company, somehow or another, that company has really taken meaningful steps. They've gone, so I love what you said. Like, you should be asking questions. You should, that it all starts with that. Like, how can we do better? What can we be doing better? Is there anything that organizations should look to as, wow, that company has really done something really meaningful?
So I'm not going to lift up a particular organization or company. What I will respond to, I think, are some of the elements that I think are models that folks can look to. And so I will tell you some of the things that maybe don't work that are important to understand. Because we talk a lot about, like, ooh, what's right, what's flashy, what's good, but we don't talk about the other side. And so I think some of the things that I see that cause me concern is when, for example, companies, organizations develop a beautiful statement, like we're committed to health equity or justice, and there's nothing following up those pretty words on the internet, right? So that's fallacy one. Because if you're going to really talk about equity, you need to make sure that you understand what it means to your mission as an organization, that the culture within your organization really understands what equity means as I do what I do. And oftentimes, again, talk is cheap. Words are futile. So how do you back that up? So I would say, to me, that is the one, I would guess, caution that I would say, make sure that your words mean something and that you really understand, if you're going to say I'm advancing health equity and I'm advancing opportunities for low-income communities and building climate resilience, that it's backed up by something. I would also say that putting your money where your mouth is, right? So again, we have places and spaces and people that talk a lot about our commitment to this, our commitment to that. Really take a look at your line items in your budget and see where your monies are going. Is it going to support, for example, community-based organizations or community leaders that you're bringing in on some kind of, maybe community committee to inform how you're doing your practices or help you better understand what your local impacts are from your operations? Are you contributing to developing climate resilience centers at the local library to make sure that not only our houseless population or our veterans or others have a place to go when it is extreme heat or extreme weather? So my thing is, the money matters, so look at where your money is going. So those are just two things that I would raise up that, as we talk about, again, this journey that you all are on and that we're on, that to me, you got to make sure your words matter and you got to know where your money's going.
Turning to questions from the audience, what advice do you have for students who are interested in making a difference in their community and potentially accessing some of the grants or funds? Is any of that you mentioned available to students?
So I have such a passion for young people, and I can say that now because I feel really old. And I have two high school daughters that are 14 and 17, and actually had an opportunity to connect with a couple of high schoolers from local high schools in Chicago yesterday. And so, oh my gosh, the fact that you were even here and taking the time to listen and learn is so important. But what I tell folks, particularly as relates to health and equity and justice, you can get no better experience than just getting on the ground and doing it. So open your eyes, look around your community, and see what the needs are, And I guarantee, having been someone that worked for a community-based environmental justice organization, we always need help. We need smart young minds. And I think what's also important in the space is the intergenerational leadership and that just awesomeness of like learning from your elders and connecting with young folks and social media, so I think there are so many opportunities. And so I encourage my students, my daughters and young people, look around your community, see where the needs are, and offer your help and assistance. Now, when it comes to the funding piece, I think, again, students, if you are connected, whether you're high school or college or whatever, to an institution or a local public health department, I think that's where you can connect yourself to these institutions and places within your community that might be going after some of these funds. Because oftentimes, I would say, they probably don't go directly to students, but it will be a local health department, a university, a nonprofit. So again, I think that connection is important, and also the importance of relationship building, right? So as students, as you think about as you progress in your career and continue to do great things, your relationships matter, no pun intended, sometimes even more than your grades, right? So make sure you take the time to build those relationships and really understand where you think you will be able to make a difference.
So there's a question in here, on how can we guarantee that projects are long-term? And maybe let me sort of characterize that a couple different ways. You talked about a number of things. You talked about money going out the door. You talked about your work internally inside the government, working across the different agencies to help them understand environmental quality and the impacts that they're doing. And how much of what you're doing, is there bipartisan consensus around any of this? Is it subject to the sort of vagaries from a Washington perspective? Is there a rich enough fabric of organizations outside of Washington that are now that have sprung up and are resourced and are empowered to continue the work beyond? And in all of that, is there anything that you're doing to ensure essentially the sustainability of the work that you're doing?
So that is such a critical, another big question, but I will try and respond. So again, the third goal of our office is to institutionalize environmental justice. Because I'll tell anybody, the work I'm doing now is super important, the here and now, but I'm worried about the after. I'm worried about when I'm gone. And as a political appointee, that's the reality, right? We have political shifts, people change. So what's important and what we're trying to do is make sure that all of this work, whether it's strategic planning with our agencies to advance environmental justice, the changes that folks are making through the Justice 40 initiative, again, re-envisioning how they do those programming and grants, that is something that we're trying to ingrain within our agencies. So it's not just the deputies and principals that run the agencies, but it's like the civil servants that are going to be there regardless of the political shift. So that institutionalization, that sustainability of environmental justice as a part of the culture is something that we are working towards every day. But I would say what's even most important is that we know as a government we cannot do this by ourselves. We have a gazillion dollars out there, but that is not enough. And so a lot of our conversations we have are with partners, non-governmental organizations, philanthropy, and other folks that have to step in and try and fill some of those gaps and really enhance the longevity. Because again, and being a former grant maker and environmental funder, I know the importance of sustainability of organizations, particularly when we're talking about our Black and brown-led organizations that are doing the work in the communities that need it the most. Oftentimes they're working with a dollar budget and doing $20 million worth of work, right? And so what we're trying to do, and one of our superpowers as the Council on Environmental Quality, is convening folks. So we can bring folks together. And so what we're trying to make sure is have conversations with philanthropic organizations and other folks that can continue to fill the gap for the long term, not just the now. So that is very top of mind for us and something that we have been, again, trying to intrinsically build into our strategy, not only at the Council on Environmental Quality, but within our Climate Policy Office, within our Inflation Reduction Act team across the White House.
That's great. Bringing it back to local, the city of Chicago, you mentioned asthma. The city of Chicago has some of the highest rates of asthma. as a result of environmental pollution in black and brown communities. Are there efforts that the federal government is taking to work with state leaders, also add municipal governments, to increase the regulations on polluters, ensure better protections, ensure the rights for communities of color, address this issue in any number of different ways?
Yeah, so what I'll say, I mean, if you're talking about, asthma, again, which is in many ways, triggered by air pollution, I'm going to lean on our folks and our partners at the Environmental Protection Agency. They are responsible for regulations, and they work, again, with their state and regional counterparts to make sure that folks are following their permits and being, penalized when necessary. Now, we can all talk about whether that is, successful in some places or not. But what I will say, it is their responsibility. And, I think so, because the environmental justice piece in this administration is so strong, and I know, again, Administrator Regan, who runs the Environmental Protection Agency, that is the cornerstone of what they do. And so what I will say is that our partners at the EPA are working very hard to make sure that, again, environmental justice and all the pieces of that come down to enforcement and compliance and how they relate to the state and local folks that are supposed to really operationalize those federal regulations. That's a part of what they're trying to do and what they're working towards. So I know that there's commitment from that agency. I know folks are working hard. I know Administrator Regan, again, has made environmental justice a cornerstone of their agenda across that agency. And so, again, we have the commitment. And I would just say and remind folks that sometimes, federal bodies, and this is the tricky part because, EJ, environmental justice, is a local thing. It's place-based. So sometimes we have limitations on how far we can reach into local places. But again, what's important is that, again, when I talk about, shed the light on things, we got to know what's happening. So if we see some inconsistencies happening across this country, then we can go in, even as a federal entity, and ask questions. Now, we might not be able to physically change what's happening, particularly local decisions, local permitting decisions, but we can at least ask the questions, raise it up, and use, again, the levers that we have to try and make a difference to address issues like asthma and other, huge chronic diseases that we know our communities are dealing with every day.
You mentioned convening earlier, and there's a question that's sort of implicitly about who's in the room. So what is your team and the federal government doing to ensure that the voices of those who are most affected by environmental racism are at the forefront of the discussions for change?
I so appreciate that. So we have, another acronym, a White House Environmental Justice Advisory Council, better known as the WEJAC. These are 24 presidentially appointed environmental justice leaders that come from different corners of the country and basically tell us how we should be doing our policy. So they are a federally appointed committee, so a FACA. They advise us, they provide formal recommendations on all of our policy work streams. So Google WEJAC, you will see some amazing environmental justice leaders that are a part of that group. And again, they not only give us formal recommendations, but they also have quarterly meetings, both in person and virtual. And at these meetings, we always have updates by Council on Environmental Quality, but we have a public meeting session, public comment session, where anybody and everybody can share, again, for 3 minutes, what you want us to know, what you want us to hear, and how we can do better, but also, how we might be doing some things right. So the WEJAC has been the primary way that, again, has kind of informed and shaped our policy. But we also have other tools that we use at the federal government, like a request for information. So you'll often see that in the Federal Register, where we're asking a question about something and we're taking in input and feedback from anybody. We also have conversations and we meet with people. So my virtual door, my real door is always open. And part of CEQ's role is to not only convene, but also to connect. Because oftentimes, and I think about when I was on the outside, sometimes, just looking at the website didn't tell me what I needed, right? And so oftentimes you need to be connected with a real person. And so what I often say is that it's our job to make sure that if there's a question or concern that is coming in from the public that we are called to serve in this position, that we should be connecting that person to the right people, because these agencies are huge, but they also have really great people that are committed to this work. So those are just some of the ways that we, again, are using, I would say, the wisdom and the lived experience of folks to really, I would say, influence and kind of guide how we do our policy making at the White House and beyond.
Well, I will say of all of the acronyms that you've used so far, the WEJAC is my favorite.
That's your favorite?
so
All
far
right.
this morning.
Awesome.
So there's another question. I don't know exactly if this is in your purview or not, but it's certainly a topic that is top of mind or comes up a lot in the Chicago area, which is that we have the largest mortality, we have the largest death gap, as the question says. So if you live in the wealthiest zip codes in Chicago, your life expectancy is something like 30 years, I might even be understating it, 30 years longer than if you live in some of the most under-resourced communities in the city. And you know, that is the result of a whole constellation of health inequities that exacerbate things like asthma and various chronic diseases. And environmental, there are clearly environmental influences on that gap. Well, that's not the whole picture, but it's a part of the story. So the question is, you know, what do you think the role of big hospitals or universities or health institutions is in addressing this issue? And if that's not exactly in your purview, I just throw it out that, like, we've got, you know, this very troubling fact about Chicago. And to be fair, most other big cities have some version of this that is, if not quite as stark, close to it. So looking at these kind of urban areas in particular, are there things that the institutions that we work with here that are part of this community should be doing about, should be thinking about differently as relates to the work that you're doing?
Boy, I mean, you know, I so appreciate that question, and just this disparity in the number of years folks can be on this earth that is, again, often guided by the zip code you live in is never something that is, that's hard, right? When you talk about, you know, your home, and I think about one of the most polluted zip codes in Detroit, 48217, and kind of the disparity in lifespan between that and some of the folks that live in our suburban communities. So that is a reality, maybe not as stark as Chicago, but that is a reality across this country, an unfortunate reality. And so when I think about the role that institutions can play, health institutions, our schools, you know, like these places and institutions that are embedded into community, you know, there's so many things. You know, we talk about the social determinants of health because it is not just an environmental thing. It's access to medicine, it's access to health care, it's being able to eat the right foods and not being, you know, like in some communities, it is only a liquor store that is there and the grocery store is like 50 miles away. So it's all these pieces that make up this community that I think the healthcare sector, I think schools, I think other folks can really dig into deeper, because that's what it's going to take. It's going to take a holistic approach, and it's not just one person or entity that can solve for this, again, conundrum of issues that result in that, again, life disparity. So I feel like, again, when you have institutions in communities, and I think about the institutions in the communities that I grew up, that I know cared about the community. So we had our hospitals, we had our churches, we had our schools that served these multiple roles because they knew what the needs of their community were. So yes, a school, you know, you send your kid there to learn something, but also sometimes these schools are shelters. They serve as places of education for families. And so really think about what are the multiple roles that institutions should play that are embedded in this community or in whatever community. And I really feel like if we go back to this concept of what a community is, and I often tease, I'm like, yeah, you know, I drive into my garage and I'm done. I don't know what's going on with my neighbors. Like, we need to get off of that. So what are the things that we can hold ourselves accountable for as institutions that are embedded in this community? How do we expand the roles that we play? And I really feel like if we just begin to take care of the little part that we're a part of and where we live, and, you know, that we would see a rippling effect. I mean, because, I mean, it's not rocket science, right? None of this is rocket science. We know what we need to do. There are resources out there. It's just sometimes the folks with the resources aren't sure the best way to use them. And so how do we hold our institutions accountable and give them like the onus to do more than kind of what they're assigned to do? So as a hospital, yes, you have an emergency room, you deliver, but what are the other pieces that you can do? Can you have, I don't know, a healthy food store, you know, that folks can access and afford? Can you have safe transportation for seniors that have to ride the bus and it's 150 degrees outside? So really, and that's why that climate and economic justice screening tool is so important, because it gives you a little bit of a glimpse of what are the burdens that a community in a census tract is facing. And really, I want you to think about, and I encourage everybody to go to that tool and say, okay, what is going on? And what are the things that are within my power and control that I can use to make it better?
Last question.
Okay.
We work with hundreds of entrepreneurs. Any advice for entrepreneurs about how they should be thinking about these issues, about things they should be doing, about the work that they're pursuing? You know, put yourself through the lens of entrepreneurship. How can we make a difference?
So, as a former entrepreneur, I feel like you have an opportunity to make social justice, environmental justice, and health equity a part of your mission, regardless of what you're doing. So while you have your, I guess your main, I'll just say, bread and butter, how do you carve out some percentage of what you're doing that's going to be totally in service to a community that you're in? So that is my challenge. How do you, going back to something I said earlier, make it not about you, but about others?
It's a perfect way to end. Thank you so much for being part of this forum and for everything that you're doing at the White House.
Thanks so much.
Let me say, that was wow. I want to give another shout out and thank you as our star speaker is taking lots of photos with folks. Let's just say thank you again for those in the room. So I took away a couple of things. I'm sure you did as well. I was listening for the unmet need, and what I took away a little bit was we heard a lot about what the federal government is doing. And in the US, what the federal government does is a trendsetter, and how do state and local governments often align with that. So it was really wonderful to also hear what's going on in Cook County as it related to the Justice 40. I heard two pain points that we might think about. How do we connect those that aren't resourced with resources? And I think everyone in this room, just the fact that you're in this room, is a connected person. And so how might we, with our networks, connect our networks with what some of the resources that we heard today? I also heard the very real pain or challenge of how do we institutionalize things so they weather the storm with the give and go of we're in a country that every 4 years we get we elect new leaders. That's the reality of our structures. And so how can we be change agents to help institutionalize some of these things? And institutionalize is another way of saying good business model fit. And how do we sustain it? And I think, again, each of us have different jobs that we do, the jobs that we've done. Some of us are leaders and we have controls of budgets. Some of us are team members and we influence budgets. So how might we also be institutionalizing some of these ideas in the day-to-day policies and procedures, the budgeting process, all standard operating procedures in the work that we do, and how might we bring more intentionality of that. I know at Loyola, preceding me, there was a commitment to be carbon neutral by a certain date. And that led to day-to-day things in purchasing and acquisition. And so when we make purchasing and acquisition decisions, the environmental impact is part of those considerations. Those are some of the ways that we have control, as we heard, on the budget and walking the talk and putting the money where our mouth is. And I'll just say one last thing, because Stephen and I were talking during the break. How do you sustain things when there's a lot of outside change that is going on, and it's very easy to kind of lose the track. And I remember in teaching health policy that policy entrepreneurs play the long ball game. They're thinking, you're not going to win the battle this year necessarily, but how am I prepared for when there's windows of opportunity, so when they occur, I can take action. So think back to the Affordable Care Act. They've been decades talking about how to improve health care and health insurance reform, and then there was a window of opportunity and there was action. So there will be moments like that we need to be prepared for. And so sometimes we can make greater progress in some years than others, but we are on that march. And that there was a book written by Collins, you've probably heard of Good to Great. He had another subsequent book called Great by Choice, and it talked about great companies that led through uncertainty and risk. And he makes this analogy of two different explorer groups, this happened in real life, wanted to get to the South Pole. One group really prepared, and they decided every day I'm going to take 20 miles. Whether it's a good day or a bad day, every day I'm doing 20 miles. The other group, they did more miles when it was beautiful weather. And then when it wasn't so good, they said, oh, it's not so good, I'm not going to do so much. And the group that survived, literally, not just figuratively survived, were the ones that in bad times and good times did that steady incremental improvement. So what is the steady incremental things that we can do each and every day that take us towards these goals? And so that's what I heard our challenge for today. And it's a nice segue into the next session, because the next session is what's that steady progress that's needed to build resilient communities, because that's the foundation if we are to be making changes and improvements on the health of our communities and reduce inequity and also the systems that serve. So the way we're doing this focused conversation section is you're going to hear an Ignite Spark talk from one of our panel members that will set the stage. Then there will be a moderated panel discussion, and that's the opportunity, again, to be able to submit questions as well. So we'll follow this rinse and repeat, as you say. So if you have a question, matter.socialqa.com. This will be the steady beat throughout. So again, same platform, just add in your new questions. So this panel is on building resilient communities. I'm going to now introduce our Ignite speaker, Dr. Nelson Dunlap. Again, if you want to see the detailed, wonderful biographies of all of our speakers, they're there in depth. But he is the Vice President of Public Policy and External Affairs at Meharry Medical College, and he's going to start our conversation. So let me welcome Dr. Dunlap.
Yeah, I'm good. Can you guys hear me back there well? All right, perfect. Good morning. Thank you for the introduction. As she said, my name is Nelson Dunlap, and I am the Vice President of Public Policy and External Affairs at Meharry Medical College in Nashville, Tennessee. That is a mouthful, and what it really means is that I was recruited to help start up the nation's first School of Global Health, and so that's what I'm doing at Meharry Medical College, the first accredited School of Global Health. Before that, I was at Morehouse School of Medicine in Atlanta, Georgia, where I worked to help lead the government relations efforts for the institution, and I was also the Chief of Staff for the Satcher Health Leadership Institute. But before that, I was in law school here in Chicago. I went to DePaul many, many years, many, many pounds, many, many gray hairs ago. So this is kind of a homecoming of sorts for me. So I say all that to say is I'm sure you're wondering why I'm up here talking. And if you find the answer, let me know, because I don't really know either, but we'll figure it out together. But in all seriousness, I want to just kind of briefly level set, right? I want to have a conversation because Dr. White Newsom just had this phenomenal and inspirational keynote, and so that gives me the opportunity to really just kind of do a call to action. And so we're going to have this robust discussion, me and my colleagues, about resiliency, particularly as it pertains to health inequities and climate injustice. But if you leave here not remembering anything else other than gray hairs, I want you to remember this one phrase, right? This one thing right here. Ask the patient, not the doctor. Just ask the patient, not the doctor. The single greatest accomplishment in my life to date, bar none, no questions asked, one of one, convincing my wife to marry me. Got her to do it, it's all downhill from there. And the reason that is because she's so much smarter than me. Like my dad is just so happy that I outkicked my coverage. But she's so much smarter than me, and she's a nurse. And so what that means is that our house runs very similarly to a hospital unit. There's a lot of, rate that on a scale of 1 to 10. And quite a bit of just kind of silent judging. And then in the middle of the night, a cup with vitamins appears on my nightstand, and she's like, take that. But what that really means is that what she has dealt with in her personal life and in her career is something that all of us kind of know intrinsically and inherently, even if we haven't put words to it. And that's if you see someone and they are in pain, and the clinical intervention for that pain is to prescribe them some kind of pain medication. Once you do that, once you give them that intervention, you don't then turn to the doctor and ask, hey, are they in less pain? You ask the patient, are you feeling any better? Did that help? Did that take the edge off? Rate your pain on a scale of 1 to 10. And so when we are in our society, when we are in our communities, and we are dealing with the pain of climate change, and we are dealing with the pain of health inequities, and we are dealing with the pain of insert your preferred ism or ill in our society, as we work to address that, we don't then turn and ask the doctor, did that work? You have to ask the patient, is that helping? Is that going somewhere? Are we making a difference? And the reason I say that is because everything that we're doing here, these conversations that we're having, the research that's going on, the discussions that will be had today, they are phenomenal, they are important, they need to keep happening, don't stop. But we have to make sure that those that are closest to the pain, closest to the harm, are leading and making sure that the path that we take, the actions, the steps that we're moving forward with, are actually benefiting the communities that we aim to serve. We have to ask the patient, not the doctor. And clearly, I forgot to click next. Boom. So I mentioned earlier that I am starting a School of Global Health at Meharry Medical College down in Nashville, Tennessee, and you can barely see, well, you can see it pretty well. You can see our vision model on the left-hand side in the globe. And I don't just put that up there because there's an off chance that my boss might see it and I'm pretty dedicated to paying my mortgage. It's because I want to highlight the intentionality that we all have to take in addressing all of the things that we have to address that are baked into the health inequities and the climate injustice of our society. And now you'll look at that and you'll say, I see entrepreneurship, I see political determinants of health, I see thriving, I don't see climate change. Where is it, Nelson? To which I would say it's everywhere. It is literally baked into every level of our curriculum. But I highlight this to say what we do here in the United States really and truthfully impacts the rest of the world. So before I go any further, let me kind of level set with what resiliency is, and I wrote this down. There's a dictionary that has some old dudes' names on the front, Merriam and Webster, and they define resiliency as an ability to recover from or adjust easily to adversity or change. Now, for some of you, it might have been that ability to recover that really struck a chord with you. For some, it might have been change or even adversity. But to me, it's the easily part, right? That's what really sticks out. The ability to recover from or adjust easily to adversity or change. And the reason easily sticks out to me because that's where the inequities lie, right? I don't know if you know this or not, but health inequities, health disparities, they exist in our society, full stop. Climate change is real, full stop. The two of those intersect, full stop. So all of our communities, whether we are aware of it or not, are grappling with or will soon grapple with the ill effects of climate change. Whether or not or how easily we are able to respond to that is what determines if our communities are going to be resilient. So now going back to what I said earlier, if all of us are facing this either now or going to, and it comes down to whether or not our communities are resilient, then we have to make sure that those that are dealing with the lack of resiliency, dealing with the lack of resources, dealing with the most immediate harms, have the loudest voices at the table. The United States of America is, for better or for worse, one of the big bads in the climate change space. And what that means is we have the opportunity to really move the needle forward. But in order to do that, we have to really grapple with and understand that this moment in time, where we are right now, November 8th, time is a flat circle, we'll never be here again. And in order for us to really to catalyze and move forward from here, we have to understand that this is an all hands on deck moment. This is a we, not me moment. Us making sure that our communities, making sure that your communities, making sure that our neighbors' communities are prepared to address what's coming and can do so in an equitable fashion requires us to understand that it's not about what I do in my household, it's about what I do for my street, it's about what my neighbors do, it's about what the folks who look like me, folks who don't look like me, the folks who are from River North where I lived in law school, the folks who are in Inglewood, you name it. All of us have to come together to actually address this, or we will all have to deal with the ill effects on the back end. But we'll get to that. We're going to have a conversation about it. And so I'm gonna say this last thing, and then I'm gonna sit down and shut up, and you can hear from people a lot smarter than me. But I want to just highlight for you, I want to kind of reiterate the three things that I've covered. First and foremost, so this is not one of the three things, I went to law school here, so I technically have a JD, so I technically am a doctor. But as I said at the very beginning, don't listen to the doctor, listen to my much more patient colleagues. But that said, I want us to never forget that you have to speak with and hear from the folks that are closest to the pain, because they will help inform what we do and how we move forward. We have to be cognizant of the fact that what we do here impacts the globe. That's making sure that the next generation of learners and leaders, the folks that are here that are learning at Loyola, the folks that are online getting their MPH from Meharry, the folks that will watch this on YouTube, the students that are clamoring for it now need to be fully equipped and prepared with what they need to fight the oncoming battles in the next generation. What they're learning today, they'll apply tomorrow. And what they apply tomorrow might not be here in the United States. It might be insert your chosen country, right? So we have to make sure that they're prepared to advance resiliency both here and abroad. And finally, and arguably most importantly, it's that this is a we, not me moment. This is an all hands on deck moment. So we all have to kind of get our hands dirty and jump into it, which is exactly what I intend to do with this conversation. I think that we're going to then pivot to a quick conversation, and there'll be a Q&A at the end. But again, as you use the QR code or the web and you put in the Q&A, just feel free to not direct it to me. That would be super helpful. So thank you. Let's get into it.
So I invite our panel to come up. On the screen, you can see all of our speakers or panel members. It will be led by Karen Weigert from Loyola University Chicago. And the panelists will introduce themselves. Karen is the executive lecturer and director of our Baumhart Center within our Quinlan School of Business. So take it away, Karen.
Thank you. As Mara said, we're going to start with a very quick introduction, and it is an extraordinary moment to introduce ourselves when we think about the dialogues that have already started today and our opportunity to go deeper and think about communities. So with that, I will pass it to Mike.
Sure. Good morning, all. My name is Aisha Jaco. I serve as Executive Director for Westside United. We're a health equity collaborative. Our big, hairy, audacious goal is based on eradicating Chicago's life expectancy gap between the Loop and 10 Westside communities, where it's currently at 14 years. So we're a collaboration of healthcare, community partners, residents, all working together, and we'll talk more about that later. So I'll turn things over to my colleague.
Hi, everyone. My name is Elena Grossman. I'm a senior research specialist at the UIC School of Public Health. I've been working at the intersection of climate and health equity for a little over 10 years, currently directing the Climate and Health Institute at the school, which brings students together with community partners and actually doing something to address climate change and health at the community level.
Good morning, everybody. My name is Linda Ray Murray. I'm a retired Cook County physician, and in my retirement, I am hanging out at the UIC School of Public Health.
Oh, y'all know me. I'm Nelson. Hi.
There you have our amazing panelists to get us started. And as we think about today, and we think about the anchoring in community and the anchoring in the groups of people who are living through, contributing to, responding, and adapting, I'd love to get a perspective. Nelson, I'll start with you just because you kicked us off. What does a resilient community mean when you think about these intersecting challenges of climate change and health equity overall?
Yeah, so I detailed the definition of resilient, but in practice, outside of the theoretical, to me, a resilient community looks like one that is not just self-sufficient in responding to the challenges and the harms of our time, but is able to do so equitably, right? We talk about equality, we talk about parity, we talk about fairness. But when it comes to your community being resilient in the face of climate change, it has to be done equitably. We have to take into consideration the historical and societal harms that have, for far too long, disadvantaged any number of communities, both socioeconomically and racially. And so it's not just a one-size-fits-all approach. It's not just kind of a block grant, for lack of a better phrase. It's making sure that whatever the history that you all have to go to the community and ask them face-to-face, what are you guys dealing with and why is this the case? You have to ask them what it is, hear their stories, and address them on a one-on-one basis to make sure that they are able to reach their optimal level of health, their optimal level of climate resilience. So to me, kind of in a nutshell, what does a resilient community look like? It looks like a community that's able to live their best life.
Aisha, I'm going to jump right over to you. I'd love it if you could give us a stronger perspective of what are some of the both assets, but really the challenges for living your best life in the work that you do.
Sure. So if we talk about our work at Westside United, we name and claim structural racism and historical disinvestment as key pillars to what we see in terms of the disparities that these communities face. So if you think about a lot of our health systems, they were built around the time of the Chicago fire. They rebuilt within that 3-year regeneration period, and they're standing today. And then if we fast forward to a corridor in West Garfield Park, which is a community that has the lowest life expectancy, that hasn't until recently seen sizable reinvestments since the riots in 1968 when Dr. Martin Luther King was assassinated. And so if you just follow those two timelines, there are a lot of through lines around inequities. And so for us, when we think about what's causing the gap, you have to look at the social determinants and drivers. And so some of the key pieces were brought out in the first presentation, with cardiometabolic disease leading in that, cancer, homicide, opioid overdose, infant mortality. And so in our work, you cannot address the life expectancy gap without not looking at housing, without not addressing some of the access points in terms of hospitals being anchors and their ability to hire locally, to invest locally. So coming into this space as an actor, by virtue of the communities that we're looking to serve, you have to address what creates a better quality of life. And so for us, as we talk about resiliency, it is also putting community in the driver's seat at these tables and giving them voice and agency. What we've heard over the last 5 years from community on their journey to live healthier, fulfilling lives is that they want nothing created for them without them. So in our governance structure, we have community members that sit across from hospital members that tell us where we should have social impact investments go, that tell us how we should recruit locally for jobs, that tell us if we're working in infant mortality, maternal child health, what strategies should look like and how they should be built. And so for us, creating a better quality of life starts there, giving them the agency because they have the genius, they know what they need the resources. And so our work is about bridging that gap and keeping that continuum at the forefront.
Linda, it's good to have a doctor on the panel. As you think about the career that you've built and the changes you have seen over time, how has this understanding of resiliency been evolving?
I hate that word. So I just, I'm not sure it's evolved, but we started this meeting doing hats off to one of our indigenous people of the Great Lakes region, the Potawatomi, they're still here. They don't have power. They're still being oppressed. That's resilience. The Navajo Nation, our largest indigenous nation in North America, they're still here, fighting and kicking. That's resilience. That mother, whether they're in West Garfield Park or Inglewood or Evanston or Skokie, that's trying to make it every day with 2 or 3 kids, that's resilience. I want to point out, since we're talking about that in time, that a little over 30 years ago, the first National People of Color Summit on Environmental Justice took place. And that summit passed, so Google this, students, passed 17 principles of environmental justice. I pulled it up here on my phone. I love technology. And one of the things the preamble points out is that we were saying in the very beginning that we were opposed to 500 years of colonization and oppression, resulting in the poisoning of our communities and land and the genocide of our people. Do affirm and adopt these principles. So when we think about resilience and entrepreneurship, I don't know where did my little entrepreneur person go? I don't know what definition Matter uses, but the last time I looked, being an entrepreneur meant, among other things, that you were a disruptor. So I fully embrace that notion. So I think that the first problem is not trying to build simply resilient communities. What does that mean? You can build a building so it can withstand a Chicago winter. That makes sense, okay, right? Or you build a building so it can withstand the summer heat. Except the problem is that our physical infrastructures are no longer able to do that because we as human beings, this is not like, oh, the climate's changing. No, we as human beings, let me rephrase that, a small, tiny fraction of us as human beings have impacted the earth so much that we endanger not only other human beings by taking stuff that doesn't belong to that tiny sliver, but by impacting the entire climate of the planet. And we endanger, I'm not worried about Earth surviving. I think Earth will survive, but we're endangering the possibility that human beings can continue to function on this planet. And so we should be upset. I'm upset. I'm glad my sister is here from the White House, but in 1991, we went fussing to the White House saying, you got to do something about environmental justice. And they put out a few RFPs. This is not what we need. We need to ask ourselves, what is necessary to make change? What's necessary to move the needle? And $1 billion, $5 billion, we are talking about committing $100 billion right now for 2 wars that shouldn't be going on, $100 billion. Okay, we're not talking about taking care of people coming across the southern border because our government went somewhere and messed up stuff. Okay, we're not talking about solving the unhoused in our nation. So I'm concerned that if we want to make real progress, we better understand our history and be willing to disrupt things.
So when we think about disrupting and we think about moving forward, Nelson, I want to ask you a question. As you're building an institution and you're thinking about global, how do we disrupt from the global level to the very, very local when we think about what's happening in our neighborhoods in Chicago?
Phenomenal question. And for me, it's really kind of a concept that you learn in improv, right? It's a yes and, right? You don't take no for an answer. And so when you ask, how do we do this from the top down? I say, yes, we do it from the top down and from the bottom up, right? So it's making sure our students understand on the academic level the impact and the role that they will have, the power that they wield. But then at the same time, it's empowering them to be advocates, to go to the local and the regional and the state and the national and the global level. It's having partnerships with folks across the board, across the country, across the globe, so that the Fortune 50 companies, the NGOs, you name it, those institutions and entities that wield the power, that small select group of humans that may or may not be ruining things, that they understand the role that they play. So when you ask me how do we do this, I say we have to do it all at the same time, and it starts with the students who are taking time off on a Tuesday or a Wednesday to be here and helping to empower them, because the next generation, like I said, I got these gray hairs, so I'm out of this generation. The next generation is going to have to continue to move the mantle forward.
When we think about the very, very local and building that, Elena, I want to ask you a question, which is, as we're thinking about communities and health and resilience and adapting to climate, what are some examples of ways that at the community level there has been a possibility to begin to build in some of this ability to adapt to climate change in a way that is ultimately equitable for health outcomes?
Yeah, I just want to say that it's always difficult to follow up Dr. Linda Ray Murray. She has amazing passion and knowledge. So there's actually a great program going on here in the city of Chicago, Our Roots. It is organized by the city and spearheaded by the Chicago Department of Public Health, but it's all about addressing the inequities of tree canopies. And they've identified priority neighborhoods based on data, both social, environmental, and health data. And they've created tree ambassadors. And this is where you get at the community level. And they are paying the tree ambassadors, so it's not, we're asking you to do this volunteer service. And they're receiving trainings on the benefits of trees, the challenges that they might get questioned about trees, and they're working in their communities, speaking to their neighbors and to their friends about the importance of trees and what are your concerns and what are your questions. And so it really is at that community level where the conversation is happening with the support of the city. So then when they call 311, we would like some trees planted in our parkway, it happens. So it's actually a really nice partnership and example of a community level work that is supported by a city level agency.
When you talk about trees, and trees have come up a couple of times as we think about the ways the physical infrastructure connects then to the experiences of community members. And as was mentioned earlier, we're seeing more and more changes in the weather. We are seeing the impacts of climate change. I think the 10 hottest years on the planet have all happened since 2010, and we had the hottest summer ever on record globally this past summer. We're also seeing storms, and we're seeing more high-intensity rain events. And so I think about the summer when it rains. And Aisha, I'd love to better understand it. How did this impact your community? What does that look like on the ground? And how does resilience, or ultimately, how does community thriving embed itself or be impacted by these climate changes? How does this move forward?
Sure. So when we say community, we're saying 10 West Side communities that range as far south as Pilsen and Little Village, as far north and northeast and northwest as Humboldt, Belmont Cragen, as far west as Austin. And as we come back east, we stop right around the near west side. And so some of the torrential rain for the weekend of NASCAR had significant implications for residents in Austin and West Garfield Park. And if we look at the disparity map, these are communities that we cluster that have the lower life expectancy, the higher rates of hypertension, like the whole piece of it. When we think about food access in these areas, and so you layer that with a natural disaster, and it's a trend that these communities have these, in some cases, triple pandemics. When we think about racism, when we go back to COVID, when we think about the comorbidities, when we think about other inequities. So this climate piece, or rain anyway, for us, it was activating the ecosystem that we're looking to build. The community leaders who are on the ground, who are first responders in some cases, and also residents, and bridging a gap where a West Side Health Authority can plug in and pull down resources from an Aetna, who can then take a laundromat and buy it out so people can go there and dry their clothes. Or to put in provisions so that people can connect into resources by having a network of whatever resources are coming from federal sources. So it's about activating this network where we are able to, again, drive resources to places where people know what they need, they know what the problems and issues are, but it's making that connection. Aetna had resources and didn't know where to go. So as a convener, it's that plugging in. And then, in COVID, we got a call at the time from Mayor Lightfoot's office, we West Side United, a combination of public health, healthcare, and community organizations to help the city think about how to address the high rates of mortality and morbidity in Black and brown communities. And the first thing we did was call every community anchor organization that had the higher disparity. So in South Shore, Auburn Gresham, Austin, and those leaders, when we think about creating a response in an emergency situation, told us where and how to work with data in partnership with CDPH, how to distribute emergency food, PPE, testing, and ultimately vaccines. So it's, again, about activating this network and this system that is sustainable so that when the next thing coming, because we know it's something, that we have a channel that helps community activate and get what they need as soon as possible.
I want to dig in a tiny bit because you threaded a couple of things, and it's the response in the moment of crisis, but then it's also the strength in the times where the crisis is the systemic crisis. And how do you manage both of those time frames?
Ooh. So I think one is the continual acknowledgement of how we got here by the actors and the people around the table. So you have competitors or traditional competitors like our healthcare partners that are Sinai, Lurie, Cook County Health, Rush, UI Health, Ascension Health, all coming around to reckon with a role that they have played in disinvestment in communities in their backyard. And so that trust building, that continual value propositioning that you have to do to show the value of why they should be part of a health equity collaborative, which has been quite nice. I think we have a very unique case here in Chicago in terms of getting people around the table and keeping them there and having them look within their internal operations to make commitments around who they hire from our zip codes, where they invest, where and how they support small businesses, how they support internships across the West Side is something that we have to continue to do. And to date, we can tell you that we've invested $185 million collectively across the West Side to diversify supply chains and to do all that. But then the next leg of our work and on our road to eradicate the life expectancy gap, we've got to go deeper to show you the impact on median income and how this process has created family-sustaining wages, how we've addressed the poverty levels, how we've addressed some of the other inequities and structural pieces that have to be factored in and addressed in order for us to meet our goal. So you do that within, at the same time, addressing Garfield Park and what's happening there in terms of food access, and Aldi's being closed for 2 years, Save-A-Lot closing about 3 weeks ago for renovations, and now there's a grocery pop-up that's done in partnership with local philanthropy, hospitals, et cetera. So it's this continuum and continuous balance and trust building also on behalf of a community that is exhausted, that is used to being overpromised and underdelivered to, on top of some of the other factors. So it's a constant walk that we have to do as a convener, but it is one that we're getting close to, I think, as a model and as a city.
You dropped a sizable number in the middle of that. Congratulations on the resources that you've been able to bring in. Linda, I'd love to ask you, when you think about communities that have been historically disadvantaged, and historically under-resourced, what are some of the practical tactics that you are seeing that have built this more sustained pathway to community health?
Well, I think in all of our communities, certainly in North America, we see a tradition and a trajectory of fighting back. That's what my real better definition of resilience. And so people that build organizations like Westside United that struggle not just for one crisis, but struggle all the time when there's a crisis and when the people downtown don't think it's a crisis, because it's always a crisis in some communities. I think one of the things that we have to do, and I say this, it's not easy. We have to struggle to understand the connections. I love your little circle that was moving around, making me a little bit dizzy.
I didn't make it, that's okay.
But Brother Dodge's circle, first of all, I want you to know, this is coming out of Nashville, they're talking about a global center, okay? There is a connection between COVID-19 and climate change. There's a causal connection between our increase in pandemics, like HIV, and climate change. And so when we understand how these things are connected, then we can also understand how the solutions have to be connected. So Brother Dawes talks about political determinants of health. Well, yeah, those are the, I don't mind. I use social determinants. But yes, politics is involved in that. Always. And the question is not whether politics are involved, but what kind of politics are involved. That's the only question. Okay. So I think that communities that pay attention, and you have to pay attention all up and down the spectrum. You have to pay attention at the individual block or family level. You want to make sure that kid actually is learning how to read. You want to make sure that pregnant mother is getting to her appointments. That's critical, but that won't mean anything. You still have high maternal mortality rates if you cannot make sure that those communities, all of our communities, have the proper investment. Why are we sitting here in our Chicago area fighting with each other as communities as we concern ourselves with new immigrants across the south border? Okay. We don't concern ourselves about the immigrants that come across the north border. There are political and historical reasons for that, but people aren't stupid. They do know we have a northern border, and they come across it just like we do in the south. But why are we fighting about that and acting like it's either them or us, or that there's a choice between people who in Chicago should be unhoused in the wintertime or the summertime? Why do we have any human being in the richest nation on the planet unhoused? If we accept that and we don't agree as human beings that that's not acceptable, it'll continue to happen. So when we move together as community, not just one little community on the south side, as a community across certainly the nation and across the globe, we failed in COVID. We didn't vaccinate most of the world just because of the selfishness of our government and other rich countries, which is dumb because we didn't know what was going to happen. We lucked up. I'll tell you, let me give you some medical advice. We lucked up with COVID. We got lucky, okay? It could have easily gone a different way. So we had vaccine, more than we needed, and we didn't distribute it in an equitable fashion to help slow down the pandemic. And we lucked up because nothing mutated out wild out the way. So I think that things haven't changed. It means going to your church group, your synagogue. It means organizing in your block club or your fraternities and sororities. It means being willing to pay attention to your neighbor's child down the street and to what some crazy person in D.C. may be doing, or Texas or Florida, or other countries.
I want to just jump in there. So the good doctor mentioned the political determinants of health that Daniel Dawes wrote the book on. And so for those in the room, I would advise you to read the book, but so that you understand what she's talking about, right? So we've talked in this setting about the social determinants of health already, and most of you know, that's those conditions in which people live, work, play, pray, and how they impact our health outcomes and our life expectancies and things along those lines. The concept of the political determinants of health is that for every preceding social determinant of health, there was some legislative, legal, policy decision that led to that social determinant, right? So let's take healthcare access, right? We talk about access to healthcare as a social determinant, and even if it's just the physical distance between where our communities are, be them resilient or not, and access to their, the distance to their primary care, that's an access issue. The political determinant is there was some zoning board, there was some decision at some point that decided, you can have a hospital there. There was a certificate of need decision. There was some legislative, policy, or legal decision that led directly to that social determinant. We highlight that not just to say that the game, not to say that the game is rigged or that, the game is over, but to say that that's a lever. There's a point of leverage there. So if you understand that there was some preceding political determinant that led to the social determinant that's leading to these outcomes, then you know that you can leverage that and do it for good, right? And so she's highlighting these political determinants of health to say, to convince all of us, be it professional or student, be it doctor or not, that there's an opportunity for us to move this forward, but you have to be willing to name it and blame it and address it and grab it by the horns before you can actually move forward. So thank you for highlighting that.
I'm going to jump in reference to what Linda was talking about, reaching out to our communities and churches and synagogues and fraternities and sororities. And it reminded me of an article I recently read in The Atlantic on empathy and how we're kind of missing empathy right now with everything that's going on, right? And, you know, it alludes to the challenges of not interacting with people and really being on our devices and communicating via social media, and not understanding and not connecting with people. And in the academic world, you know, that's called social capital, right? And just like, basically, the way that I think of social capital is I know that I have someone's back when I need help, and I got someone's back when they need help. And there's actually research around this that it is a protective factor. It totally helps build resilience. And Eric Klinenberg is a sociologist. He wrote the book Social Autopsy of a Disaster on the '95 Chicago heat wave. I highly recommend it. He also recently wrote a book about, I think it's called Castles for the People, or Building Castles for the People. And it's actually around improving civic engagement, around how we design our communities, and intentionally designing communities that we interact with people so that we are building those relationships. And there's a direct connection in civic engagement and climate change and social capital. And I think also helping to increase the feeling of empathy that I think is lacking right now, which supports both this need to build resiliency in the face of climate change, in the face of migration, in the face of food injustice, you name it, right? But understanding that there are, whether it's your neighbors directly next to you, down the city from you, or in a different state, that might be struggling with something that maybe you aren't struggling with, but you can understand. So I think that is something at the community level, this idea of building social capital through how we design our communities can really play a key role in building resilience.
When I think about social capital, and I think that bridge from empathy, it speaks to so much of what the foundational concepts really are. It's no one is the other. It's that you see yourself in everyone. I think about how that becomes applied, and Aisha, I think of intergenerational collaboration, and I'd love to know, how does that get fostered and strengthened, and how do you truly bring the voices of all different ages into your work?
Sure. So at our Community Advisory Council level, you have Ms. Angela Taylor, the curator and grandmother and unofficial mayor of West Garfield Park. So she brings her wisdom, and if you ever go to one of her markets at the Hatchery or go to the pop-up grocery store at 4300 West Madison, you're going to see her granddaughter on the register. So it's that dynamic that we help just activate. We have Emma Lozano, who is an activist, pastor, who has a heavy footprint between Humboldt Park, Pilsen, Little Village. Her daughter, Tanya Lozano, is also a champion for us in our work. And so for us at the Community Advisory Council level, it is important to have that resident CBO leader mix to help inform strategy. We don't have a youth council, but we do have work that takes place in schools. We've built a cluster of care hub at Herzl Elementary. We've gotten feedback from young people in that space. So we see it play out when we step to a table that, like the Garfield Park Right to Wellness Collaborative, where you have a mixture of Rush, Erie Family Health, the Garfield Park Community Council, where Angela Taylor also represents, and them going after the pursuit of their first ever quality of life plan, curated by LISC. And so that process brings the entire community out. And so as a convener, we're part of helping to channel those insights that create this 10-year plan for community. So you see vignettes of that. At our onset, we had community listening sessions where we went to talk to community once hospitals came together to say, we will work together to decrease the gap. This is our aim. Part 2 of that was taking it to community, so that this was not a prescriptive model, telling community what they needed. And so that was a series of listening sessions where we talked to over 1,000 Westside residents that was varied in age and ethnicity, if you think about a place like Belmont Cragen and some of the border communities. So For us, it's very important to constantly check in through surveying and hyperlocal convenings just to get the pulse from a variety of voices that make up community.
When I bridge between the voices of community and the idea of social capital, and I bridge to the physical changes that are happening with climate, you have to think about infrastructure and the physical world around us. And you mentioned Elena, you mentioned Eric Kleinenberg's book on the 1995 heat wave, and some places in Chicago were physically hotter. Like, it was physically different. Some places in Chicago had different levels of social capital. There were different kinds of risks on top of different levels of heat. And I'd love to get perspectives from all of you on how do you manage both of those, strengthening the community, the social connections, the life opportunities, and changing and incorporating the physical needs around so that you're not starting from a very different starting point. On a hot day, it's just hotter in parts of Chicago, and there are historical reasons that are difficult and unsolved still to this day. How do you balance those two things?
First, I think we have to be careful about how we define things. So I grew up in the projects of Cleveland, Ohio. Trust me, I'm old, so the projects when I was there are not the same as the projects today. I'm willing to acknowledge that. But I think every community has social capital. The question is, what kind of social capital? Okay, and who has currency in that setting? Is it someone serving on the corner or doing other things? And I think we have to institutionalize it. You know, Westside United is such an important community coalition, 14, 15 years. I thought it was older than that, but anyway. So we do have in Chicago a rich tradition of local community-based organizations. But I think we need to institutionalize some of these cross-generational things. For example, we're about to move to an elected school board. So what have we done? That's different than our local school councils. This is in Chicago. In the local school council, you just had to be in the neighborhood to vote. And so that means if you were here without the white man's paperwork, undocumented, you could vote in the local school council, and you could serve on the local school council. Now that we're making that part of our regular electoral process, that whole community who provide many, many children to our school system will no longer be able to vote. And ain't nobody put no students on the local school councils or on the big board, on the citywide board. Now, I'm not saying sixth graders know what they need to learn. 16-year-olds do, because I knew everything when I was 16. And it's been going downhill since then. But anyway, so we can have and should have students on all of that process. Just like we can make sure that we have seniors. And just like for things that don't require a constitution, like trying to have good input into your schools, who says you have to have the white man's piece of paper that says you can vote? So I think that we have to be very careful. Every community has social capital. Sometimes social capital builds communities and builds our ability to survive, and sometimes social capital destroys communities. And one way to destroy community is close schools, and we've been through that in Chicago. Don't underestimate, these things are connected, solutions are connected, and the causes of the problems are connected. So when you close 50+ schools, it's really much more than 50, 50 was just that 1 year, you destroy communities. You destroy positive social capital, if you will. You destroy the ability to have a high school with a basketball team. We have some high school buildings with 200 kids in them, 150 kids. You can't offer the courses you need if you only have 150 kids because you closed all the elementary schools that feed that high school. So again, to me, we should be very careful about our academic language and understand that what's going out there in the streets has been going on all the time. Some of it is positive, a lot of it is negative, but the people involved are trying to do the best they can to survive. And I agree with my brother, you got to listen to the patient. Or the real secret, he said at the very beginning, I want to highlight this because the nurses run it. So I personally, I always listen to the nurses first and then the patient.
Yeah, me too, because I want to continue to stay in my house. I will say, you know, I think that a lot of communities, most communities do have social capital. For me, it's about telling the story about that to help actually get the word out, right? So when I'm talking to students, when I have on my government relations hat, it's about telling a captivating story that really illuminates what's going on. Because a lot of us in this room, y'all are all very smart. Y'all might be nerds. We don't know. So those numbers will stick with you, but the vast majority of people, they don't care about the statistics. They need a story that will help resonate with them. For me, when I think about, I was talking to some students a couple weeks ago. I'm from the great country of Texas, okay? In 2021, there was an ice storm, and a lot of folks remember this ice storm that shut down that entire country. So I want you to just envision with me a hypothetical, okay? 60-plus-year-old black man, married, congenital heart defect, so not even anything he did. He was born that way. He's now on the heart transplant list. He has a left ventricular assist device that keeps him alive. He plugs himself in at night, and when he's out ripping and running, as the old folks say, he's got batteries that keep him alive, right? So he is reliant upon electricity. Power goes down in the entire state for a week. What happens? Now that's a climate change issue. And if you're on the lower socioeconomic status side of things, what happens? I know in Texas, I think 246 people died during that period of time. I can tell you that man didn't die because he's still bothering me every week because he's my father. I was able to pick up the phone and call their state representative because I went to high school with them. I was able to, reach out to some of my homeboys from back home and say, y'all need to get to Lowe's and get a generator to get them. These are things that I was able to do because I'm in a different tax bracket, for lack of a better phrase. But for that instance, he wouldn't still be here. Again, no fault of his own, congenital heart defect, just happened to live in the greatest country in America, right? So what do you do about that? You tell that story, and then all of a sudden it clicks, like, oh, so this is a thing that can impact any of us without regard to how I voted, where I live, how much money I have, my student loan debt, you name it. And then it becomes real and it becomes tangible, and they realize, okay, this is something I need to be activated about. So I think that social capital is important, but I think you also have to be able to tell the story that gets to people very quickly so they can understand and they can buy in, and they can understand my plight of having a father who thought he was close to death and now he's just bothering me. But we'll live and we'll learn.
I'm just going to reiterate the power of the story. I don't know if you're familiar with the sitcom Parks and Recreation, but Leslie Knope once said, all I have are facts and science, and people hate facts and science, and that was in reference to trying to put a fluoride in the Pawnee water system. But it's true. I mean, we don't connect with facts and science, right? We connect with humans. We connect with stories. And that is a way that can build positive social capital by sharing stories. And I always encourage everyone to find your climate story that you can then share. And I think, connecting it back to the physical structure of a community, there are many ways to design a community that can both help mitigate these climate disasters while also supporting positive social capital. Whether it's just making places where people can interact with each other, that's green. But even like libraries, public transportation, right? So you are going to interact with people that you might not typically interact with. So, I think that that's like a nice way to support both physical changes and social capital. And I will say that, that we can't just any one way our way out of this problem, right? It's going to involve lots of solutions and being creative with our solutions.
And telling some stories that illuminate them. We mentioned public transportation. One little detailed story that I often tell people, because they'll ask me about electric vehicles, and they'll say, I've never been in an electric vehicle. My community doesn't have electric vehicles. If you've ridden the CTA and you've ridden the trains, you've been on an electric vehicle in the city of Chicago. There's a story that we're all a part of when we ride that train, and it is not emitting the pollution that is impacting so many of our communities. I'd love to know other stories. We're gonna pull in the audience in a couple of minutes. As some questions are popping up, definitely upvote the ones that you're excited about. What are stories of things that you want to see more of? I shall start with you.
That's a loaded question. Well, I was asking Linda, where was she in 1995? Hailing from the great Cook County Hospital, and she couldn't recall if she was there, but that opened up just some dialogue. So I think I agree. In order to gather those stories, where are the places that people come to share? And how do you curate that? Because it's going to be critical on our journey to eradicate, right, this life expectancy gap. As mentioned earlier, it is an all-hands-on-deck approach. And one of the ways in which we set up our foundation was from stories. Going out, we had the quantitative data, we have the decomposition analysis, we know what's causing the gap, but in order for us to build our framework, we had to hit the ground and talk to people. And we built a tool, a learning map that's digestible, where you can look at life expectancy, you can look at the assets in community, and people interacted with that. Oh, that's my conservatory, or oh, that's my park. I'd like to walk it, and these are the factors that are inhibiting it. So some of the most powerful information that we got was from hitting the ground, setting up platforms, or going to where people are in the church, in schools, and other places. So in terms of the type of stories that I'd like to hear, there's a story out now about West Garfield Park being the most violent place to live in Chicago. And they feature different resident perspectives, and you'll hear more about Angela Taylor this week. There have been several stories about the West Garfield Park pop-up. I want to hear stories. I agree with you around resilience. We have people that come here bringing many things, and they have many journeys. So, when we look at folks that are outside police stations that traveled in some cases through jungles to get here, I want to follow that story. I want to see that story. I want to see how that family is going to evolve and get the resources that it needs. The other side, I want the stories around commonalities and the communities that embrace the people that are in search of what we all want and have access to. So just something that came.
I'm just going to quickly comment, Dr. White Newsome had said that we should also tap into what the Native Americans have done, right? And they have a history of storytelling. And we should definitely consider, that is a great tool, and think about how they did it and what they did, and incorporate that into storytelling.
I think everybody can do something wherever they are. And so one of the stories that I like to tell, I wish I could say this is no longer a story, but this clinic has fallen by the wayside. But for a decade or so within Cook County, now so all the things you hear about Cook County is only the surface. It's so in the Cook County system, okay, for a while existed a program called Project Brotherhood. This was a black men's clinic on the south side where I accidentally was seeing patients. And this is a hard thing to get in any kind of big medical system, not just the government system. But all it required is sneaking an hour or two from our regular clinic schedule and adding an extra hour or two on after the regular clinic normally closed and saying, yo, this is for black men. Okay. Now, sometimes you see that for women. Well, sometimes, sometimes you see it for women or young girls, but this is for black men. Because the only people that have worse health status than black men are who? Native American men. Okay. And we got from our providers. Now, we don't want people to work for free, so our clerks and our nurses, we pay. But we got from our providers, our physicians and mid-level providers, as well as our administrators. We got a little bit of volunteer time because they wanted to see how this experiment would work. And we didn't just come in and take blood pressures. In fact, when you came into that clinic, nobody approached you with a thermometer or a blood pressure. We had some food, and the brothers were in a circle, and they talked about stuff. I wasn't in the circle, so I know that they were there for a couple of hours, talking and laughing and crying. And once in a while, one of them would come in the back and see me or other physicians as a physician. And the few black men, because we don't have enough black male doctors, the few black male doctors that we had in this program, we never let them all see patients the same night. And they would sit out there in the circle. One or two would be in the back with me, but half of them would at least be out in the circle. And I talked to brothers, they would come every week for 3 or 4 weeks, and they say, I didn't know this guy was a doctor. But they were willing to go talk to him then because they had been sitting next to him for 3 or 4 weeks. That program was really cheap. We had to pay a few dollars for social worker. We had to pay some money every evening for a barber to come into our clinic and cut heads for free to the patients, okay? And anyone who understands black culture knows the power of a barbershop atmosphere. So now, that doesn't take a lot of money. Yes, they tried to get grants, and they had some grants. And so, you're right, and the grants lasted a little. But that's something an institution can do. There are some things that even struggling hospitals and academic centers is chump change that falls on the floor. You can set up a special hangout center for teens in your neighborhood. You know, you can sponsor, not just sponsor a little league team, but you can do things with students. You can have the students come in on Saturday mornings and look at a microscope. So there are things that people can do, and this builds trust, and it builds resiliency. And you can guarantee that it stays there even when that little HCOP grant or whatever grant starts it off disappears. And that's what we need more of.
Very quickly, I would say we need more wins. And this is really more so for academia, but a lot of times when we do research, when we do studies, we look at the deficits, we look at what's going wrong. And going back to what I was saying earlier, we need to highlight the wins. We need to highlight where things are going right so that there's a model for people to aspire to and to emulate and replicate. So, as we move forward, just make sure that you're highlighting the positives along with the negatives.
Awesome. We've got some questions. Yeah. Aisha, you're the top question at the moment, so I'm going straight to you. I'm just going to read it. It says, how do we build trust between the resources and organizations available to help the communities that need it most?
Woo.
Yeah.
It's quite a process and journey, but I think people have reacted to, in our space, the ability of those in power, the traditional power structures, to acknowledge their privilege and to level set on the role that they played in the problem that they're trying to solve. That goes a long way. And continuing to work alongside that to give agency to the people that you're working with, working with. So I think that has been critical. And then at every level, there's something. When dollars start to flow in to a place that has not seen sizable investment, there's another trigger of, is this really going to come to me? Or we should be in, so there are nuances that you have to think about when you step into spaces, particularly when you're driving investment. Listening is 100% of it also. And I think you mentioned that earlier. You did. To the patient, to the community, that's half the battle, being able to level set. I often think of one of our champions, Dr. David Ansel, and his book, The Death Gap. And when you talk about stories, that's what pulled me in as a young black girl from the west side of Chicago. I'm like, who is this guy talking about the Ogden Corridor where my grandmama was? Wow, he made it real. I was able to relate. And that's so critical. So I would offer up those pieces, is going in, owning who you are, and while you're at the table, listening, and then working in an authentic way to maintain and to continue to build trust through that relationship, however that shapes up.
There's another question here, and it asks about legislation. And it really says, if you could pass one piece of legislation to support our communities, what would it be? Is there a legislative side that we haven't talked about enough?
We're challenged right now in the United States for democracy. It's not a new challenge. Look how long it took us to get on paper universal suffrage. A long time. So let me just say one thing about health. So I don't think there's one piece of legislation. Let me point out one thing about health that we know but we don't often talk about. We don't have a public health system in the United States of America. It's against our Constitution. Health is a state program. Now, we have a lot of federal money, that don't get confused, but health is controlled by the states. And so it's not really constitutional for us to have a coordinated, I guess we could still be coordinated, but for us to have a national response to major pandemics, et cetera, climate change and the like. So I'm concerned personally about our ability to vote. I think we've lost ground on that. I'm concerned about the Electoral College, you know. So I think we're in big trouble in this country. I don't think we're particularly following, I don't think we don't get a good grade as a democratic country is what I'm trying to say. And so rather than one piece of legislation, I think we have to really look at that. What do we have to do, talk about trust, to allow people to think, to trust that if they go into an election booth and vote on something, it might actually get implemented. That's the reason why people don't go vote. All right. That's really they don't think it's going to make a difference. That's what the young people say. They don't think it's going to make a difference. And it's really hard for me every year. It gets harder every year. I mean, I go vote every year, even if I have to vote for my dog. I go vote. You know, people died, so I go vote. I've written in all kinds of people over the years. But it's harder and harder for me to convince my young relatives that they should go vote because they don't think it matters. They don't think it makes a difference. And until we get to the point where people think even sometimes it makes a difference, then I think we don't need to be talking about specific legislation. But if I had to pick one thing, it would be free education. And then the second thing would be universal health care. Those are my top two.
If you gave me the choice, and I could vote on your one, I'd probably wipe out the student loan debt. No, in all seriousness, it would have to be something around extending postpartum reimbursement. You know, every now and then there's like a news cycle where people really understand how grave and how dire maternal mortality is for women of color. Like even when you disaggregate by socioeconomic status, you know, we're talking about doctors to, the lowest socioeconomic status, and we're seeing the same kind of outcomes. And so if I could do anything, it would be to really try to address that. I mean, I don't know if you guys know this or not, but I'm black, so I'm the product of a black mother. Huge fan of them. 10 out of 10, 5 stars. That's how I got here. So, that would be, if I had to pick one and I couldn't pick wiping out these student loans, Joe, it would probably be that.
And the impacts of heat and climate exacerbate.
Yeah, I mean, it's everywhere, right? Like if you're struggling with access to, seeing your doctor and you're reliant on public transit and it's in a place where it's 110 degrees every day, I've been around enough pregnant women to know they're not super into being hot, right? And so it exacerbates it, right? And we're talking about we're in Arizona this summer where it was so hot that people were getting burns, just from being on the asphalt. That's not just like a story. Like that's a real concern for women. So like across the entire continuum, we should be protecting, the folks, the birthing women who are going to create the next generation. And so I would extend that if I had one vote. Again, that's if I can't get these student loans knocked off. So that's always the caveat.
I'm going to combine two questions, and I'd like you just to pick whichever answer jumps to you. What thoughts and guidance and advice do you have either for students or for entrepreneurs who are excited about the topics they're hearing about today?
Do something. Do more than you did yesterday. That's my advice. I almost don't care what you do, but just don't sit around and do nothing. Do something, and you'll accidentally maybe discover something good.
I would say talk to someone you don't know. Like reach out to someone. Create relationships, build relationships. I think it's so powerful, and share your story. I think it's something that we're really missing in our society right now. There's a climate scientist, Katherine Hayhoe, who is amazing, and she really focuses on communication, and she'll always say, you have to talk to your neighbor. So I would encourage, it has nothing to do with education or creating new businesses, but talk to someone you don't know.
You might have everything to do with education and starting new businesses.
And I agree with that. I do have to go back to you, Dr. Linda, about disrupting. Think big, be okay with being uncomfortable, because you're going to have to consult from within on a lot of different fronts. But when I think about this working space that I found myself in, a lot of the magic came from people being uncomfortable, people naming and claiming some of the structural issues that have been drivers in the disparity that we see, and then thinking big enough to finding a big solution or asking a big question that requires a big answer is, I think, where the magic is. No fear, go for it.
I would say within reason, ask for forgiveness, not permission. And I think that's for both students and innovators alike. History is written by folks that have just saw an issue, saw a need, went for it, and we'll address the issues on the back end. We'll ask for forgiveness after we've done it. Last year, the AMA had their like annual conference in Hawaii. And going back to how smart my wife is, she's not here. She didn't come with me on this trip to Chicago, but for some reason, she was with me in Hawaii. She was like, yeah, I guess I'm going. And there's an FQHC out there in the Kalihi Valley, and they've been around for years. They have a physical footprint. They've got doctors and a wellness center. But a couple years ago, they decided we want to go after 100 acres of land in the valley to have space to train Native Hawaiians, to focus on plant medicine, to kind of reclaim our space and our time and address some of the climate concerns and make sure that we've got green space. And that's not something that you normally hear from your FQHCs, but they said, we're going to go for it. And it was phenomenal. You know, it was great to go out there and see what was happening. And it's kind of one of, you know, not so many. But the leadership said, we're going to go after this. We're going to ask for forgiveness, not permission. And the end result is, you know, it should be elevated. So if you're a student, if you're an innovator, if, you know, you're a patient, if you're a nerd, if you're an insert, you're, you know, preferred, whatever, go after what needs to go after and just, you know, whoever be damned.
When I think about this conversation on communities, climate change, health, and equity, you all just summed it up so nicely. So first of all, you got to talk to somebody, get to know somebody, and then you actually have to take some action. You got to go do something, and that something's probably going to be disruptive. So you got to actually do it. You might want to ask for forgiveness afterwards, but no matter what you do, tell your story so people are engaged. So thank you.
That was an energizing set of discussion. Thank you. For those that are here, local in Chicago, we now break for lunch, and there is food around the corner outside the door. For those that are with us online, we'll be breaking for about an hour. We'll come back 12:50 Central Time. Thank you. Excited to have our next panel. If I can move the slide. Here we go. So, the morning kicked us off and inspired us. We talked about the foundation that's needed with the resilient communities from which to begin to think about how we address health inequities caused by climate change, which will be the focus of our next panel discussion. But I thought it might be just useful, since some folks are new coming in after lunch with us. We're on this entrepreneur journey, and so some highlights that I took away for myself and inspiration. I think it was Dr. Linda Ray Murray who said, we are entrepreneurs, and that means we're disruptors. I think I also heard that we should be seeking action and ask for forgiveness, not permission. So think big in what we do, but think local in what we do, in that listen to the patient, listen to the community. I see one pain point, and this might be an area for further dialogue. I think many want to engage with community and make sure that we are we're listening and developing community relevant solutions, if you will. But what's for lack of a better word, the marketplace that connects those that might be in a private sector role with those that are in the public sector or nonprofit or community engagement that, for instance, like leaders like Westside United do. And how do we create that kind of marketplace that brings those people together easily? Because I think that's a pain point that sometimes gets in the way of that collaboration, and recognizing that collaboration, as we heard, requires trust. It requires humility, and that takes time. And the urgency to act right now on climate is time sensitive, right? And so we've got to catalyze our ability, I think, to listen to the patient and to community and find ways to do that faster. So those were some things I took away of things that getting me to think how I might contribute to that myself. So we will be now led similarly in a panel style, that we will have a mini kickoff, insight, kind of ignite session, and then lead to panel. You'll have the same opportunity to enter in your questions for those that are new. It's matter.socialqa.com. Just enter in your questions, and so then when our moderator, Dr. Malik Henfield, who is our Dean of Loyola's Institute of Racial Justice, who will be moderating this panel, gets to the Q&A, he'll be working from that. So without further ado, I'd like to introduce now Andy Garman, who's a professor at Rush University and among the senior leadership and development advisor with the IHF Geneva Sustainability Center. So we'll kick it off to inspire us as how we think about the health inequities that are caused by climate change. Dr. Garman.
I think I've got a... All right, welcome back. After lunch, everyone's awake, excited. Had some great presentations before lunch. I'm going to try to keep the trend going. We'll see how we do. I'm going to speak a bit about this organization that I do some work with, the International Hospital Federation, but I don't want to gloss over the great work that's happening at Rush University Medical Center. I see some folks here in the audience from Rush. Give a quick wave, because we're going to do some meetings and things later. Ian Hughes, Katie Pittman, Sadie Jova, great to have you here. Rush is one of the organizations that signed the HHS pledge. We're right now standing at 15% nationally. Not a great number, but trending in the right direction, as Elaine would say. We're going past early adopters, moving towards early majority. So that's definitely the direction we want to go. What I want to speak to a little bit, since I've got a little bit of this kind of international perspective, is equity considerations on multiple scales. I'm also going to introduce this organization that Elaine mentioned. The International Hospital Federation, you can think of it as an association of associations. So American Hospital Association here in the United States is a member, American College of Healthcare Executives, HFMA, HIMSS. It was established in 1929. It's run out of Geneva, Switzerland. It has about 130 members. It's the voice of hospitals on the global stage is the way to think about it. About 25,000 hospitals in total. And they look to this organization especially for global innovation that can be implemented locally. Increasingly, especially since COVID, that global innovation has focused on, well, what are the problems that we're all sharing in common, and how might we come up with collective solutions? So these are 6 of the areas that this Geneva Center works on. The Geneva Center is much newer. It was established about 2 years ago. So I do that work remotely. It starts about 7 o'clock in the morning. I'll run until about 10 o'clock, and then I'll move on to Rush work. The one that I have lassoed over here, understanding and addressing the determinants of health. And we've heard a few qualifiers on determinants so far this morning. We heard social, of course. We heard political as well. Commercial determinants of health is another one that's starting to show up on the radar, at least in some of our other countries, and the vulnerabilities of the communities that we serve. So I want to present 4 scales, 4 lenses through which we might think about inequities. And we heard the Merriam-Webster definition of inequities. The way I think about inequities, if I was to boil it down as far as I possibly could, I would boil it all the way down to fairness. And fairness means different things to different people, but these are 4 that have resonated with me. I think you'll start to see, I hope you'll start to see a few threads with some of the conversations we've already had. The first scale is this individual scale. So if we're talking about decarbonization, if we're talking about the need to tread more lightly on the planet and push less carbon pollution into the atmosphere, this is not an evenly distributed problem. If you look at the top 10% of emitters at the individual level, that's about 52% of the emissions right now. This is a scale from 1990 to 2015. By the way, this is an analysis from Oxfam. They're a UK nonprofit organization. If you look at the poorest 50%, that's about 7% of the emissions right there. So when we talk about the solutions, it is very important for us to keep in mind where are the inflection points and where are the structural challenges that we need to be thinking about, that we need to be addressing. So that's scale one. Scale two, I don't think I can top the terrific discussion from this morning about it, so I'm not going to focus too much on it. I might just point us to this graphic on the right-hand side. This was a relatively recent study. This is a holdover of redlining neighborhoods, and it relates it to tree canopy. Tree canopy was something that Elena was speaking about a little bit. I'm not going to get into the statistics on this one. I just invite you to take a look at the trends. The neighborhoods that were identified as the A class, much better tree canopy. There's a relationship between tree canopy and surface temperature. There's a relationship between surface temperature and heat-related illness. So these are structural inequities. They were started in the 1930s. They persist to this day. There's a real need to be addressing these in a more systematic fashion. This one on the left, this is National Defense Resource Council. Great data coming out there, and if you're a data wonk, this is a wonderful era to be looking at environmental justice and the like. But it's just to say this is not a randomly distributed phenomenon that we're looking at. When we talk about structural inequality, environment, you can just lay that pretty much right on top of the existing maps you may already be familiar with. All right, so I want to zoom out a little bit now. I want to say a bit on global. This is a graph that I put together for a master class I ran a couple of weeks ago. Ian was in it. It was in Lisbon, Portugal. This is the list of the nationalities of the folks who were in the room. So it was a way to kind of get a conversation started about decarbonization. If you're looking at the Paris Agreement, the goals, if you want to be ambitious and say, well, we need to decarbonize 50% by 2030, we're looking at a world average right now 4.7, so a world average that needs to be brought down to 2.35, let's say. We've got the United States up here at 14.9. The United States does not need to cut its emissions at half. It needs to cut its emissions in more than half. You look at the countries like Somalia, Rwanda, they're already way below 2.35. And they're developing nations. They're looking to provide for their citizens what we've been able to provide here in the developed world, in the developed nations. These are not countries that we could possibly, from a fairness perspective, ask, hey, how about you start to decarbonize? Yes, we were all having this carbon party, but now the party has to stop and we all have to equally cut in half. So this is a challenge. And you see the regions up at the top. The more access you have to natural resources, the more likely you are to use them. That's all that's really saying. And if you look at the healthcare organizations, this just was not on our radar to be focused on until very recently. So these are the kinds of things that we need to kind of start thinking about and having conversations about. This is another look at sort of the disparity between who's pumped the carbon in and who's the most vulnerable. I won't get into too much detail on this. If you're interested, if you go to carbonmap.org, you can see all the data behind this. These are people currently at risk, proportionately speaking. This is not climate change in the future and what might happen. This is what is happening right now. And this is historical emissions. So you can see there's some real discrepancy between who's doing the emitting and who's feeling the impact. So you want to talk about impact and come up with a narrative about it that's pretty compelling. There are some island nations that are looking at going underwater. They're looking at losing 100% of their land between now and the end of the century, 2100. And this is starting to raise questions about the legal definition of a nation state. And can we continue to exist as a legal entity if we have no land? Land currently being written in, as it is, to nation state law. So some of the things that we'll need to grapple with, think about, and hopefully start to have this conversation not just about ourselves, not just about our neighborhoods, not just about our country, but thinking about the fact that we have the one sky, we have the one atmosphere that we all need to share. So I'll do one more scale. This is the temporal, or the time scale. What I tried to do here is, this little line over here is our current global average life expectancy. I think it's 70 plus or minus. This is the people who are alive today. This is the size of every person who ever lived, at least best available science, about 160,000 years. Homo sapiens have been around. That's the amount of time they've been around. And if we take this and we think into the future, I just took those two boxes, I moved them over here. So this is past and present. If we just use the number of what on average is the length that a species gets to hang around on the globe, that's about 1 million years for your average mammal. So this is very conservative. Move the past to present. If we just stuck around for 1 million years, like we figure this out, we move things forward, this is the size of every person who might live in the future. And that's assuming we're not very clever, we don't figure out ways to extend the species. If I took this and I shrunk this one down, and then I created another box, which was how long we could be on this planet before it becomes uninhabitable, the sun grows too big, that dot would be so small we couldn't even see it on the slide. So just another way of thinking about whatever we're doing now, it's an inflection point for whatever could theoretically come in the future. And you talk about voices that aren't heard. The people who aren't with us yet is a set of voices that we have to imagine, we have to try to create the empathy within ourselves. So Elaine did mention, wanted to talk about innovation. So this is my last slide. I'll mention a few of the innovations that I think we need. I'll mention also a couple of things that the Geneva Center is working on related to these. One is learning, changing mindsets. I'm a psychologist. This is kind of what I bring to the Geneva Center, or attempt to. I have something I call experiential travel to alternative future states. We're doing a lot of development of simulations. We put somebody in charge of a hospital. We tell them they need to decarbonize 50% in the next 7 years. We give them some choices. They have to balance this against other considerations, finance, employee experience, quality, et cetera. So that's one area. Measuring, finding and sharing the metrics that matter most. We're just kind of on the cusp of starting to get our heads around even measuring carbon emissions, scope 1, 2, and 3. That's just a starting point. If you look at Johan Rockström's work out of the Potsdam Institute, there's like 9 dimensions that we need to be managing and monitoring and thinking about how they relate to one another. And then if you look at Kate Rayworth's work, Donut Economics, it's how do we balance that influence, that impact on the world against what we're trying to do for every human who's occupying it. So what the Geneva Center is working on here is what they call a sustainability accelerator tool. It measures environment, it measures social, it measures governance. And very excited to announce we just signed a relationship with the American Hospital Association. They're going to be promoting it out to the US hospitals. The ambition with this is that we'll be able to measure and compare ourselves globally to what every health system is doing and find the best practices and move those forward. Last two, financing and policy making. If we think about that sort of funnel that we were looking at before, and if we talk about even entrepreneurship, reconsidering what it means to win, what it means to succeed. This is something that I think is worth giving some deep thought to. And gross domestic product has kind of had primacy for many years. There's a lot of thinking outside of the US that that's really not the right metric. We need to kind of toss that and start thinking about, well, if we were to measure well-being as the primary focus of all economic activity, what does that look like? How do we measure it? How do we start to focus on this a bit? When I talk to young people, that's not me, that's other people, I'm not in that category anymore. There's a hunger for that. There's a recognition that, okay, this has taken us so far, but we need a new direction going forward. Thank you very much for your time, and look forward to participating on the panel.
So I invite the panelists up, and we'll just have it so that Dr. Henfield, just a brief introductions of folks. Again, for those that are new, if you look at the QR code, you can see the very detailed backgrounds of our excellent speakers. So I'll hand it off to you.
Good afternoon, everyone. I hope that you all are feeling energized by what you just heard, building on top of everything that you heard earlier this morning. My name is Malik Henfield, and I'm the founding dean of the Institute for Racial Justice at Loyola University, Chicago. Essentially, what we do is use research to tackle really big, complex problems, like everyone else in this room. What may be different about us is that we focus very narrowly on race and all of its intersections. And when we think about the fact that we're trying to figure out how to make lives better for people, whether we want to or not, we have to understand the fact that we have all been racialized in some way or another. So rather than thinking about data on an aggregate scale, we try to drill down as deeply as possible in collaboration with people like all of you in this room to try to get at what are some of the ways that we can move forward, whether it be policy or actions that can be taken at a global down to a micro scale. It gives me great pleasure to pass the microphone down to everyone else on the panel to introduce themselves as well. Andy, do you want to touch on?
They've heard enough from me, but thank you.
Jared.
Good afternoon. I am Jaren Cheek Butler. I'm the Deputy Director for the Office of Health Protection at the Illinois Department of Public Health, which is just a fancy way, an extremely long way, to say that I work in the space of environmental public health. So I work on everything from toxicology to childhood lead to lead removal, asbestos, vector control, and our really big program is our food program, and we touch on food inequities. We touch on a lot of environmental things that we just have finally started putting together to also talk about what the inequities are. So this is a new space for us that we're putting all of these things that happen individually together to bring them together and look at them as a whole. So I guess we're going the other way from drilling down. We're actually taking a step back to look at it at a micro level.
Hi, everyone. My name is Nancy Cohn. I'm with Healthcare Without Harm. And for those that might not be familiar, we work with the healthcare industry to reduce its environmental footprint and to be leaders within their communities and globally to promote environmental justice and public health. My role at Healthcare Without Harm is Eastern Regional Director on the Healthy Food and Healthcare team. And what that means is I work with hospitals and community partners to pilot and scale models based on creating a more equitable, resilient, and sustainable food system. So really working within food and nutrition services within hospitals and making sure that the community hospital voices are heard together.
Thank you all very much. I'd like to begin with you, Nancy. But before I do that, I want to publicly commend the Parkinson School for Public Health, as well as Matter, for forming this panel and inviting me to be on stage. Oftentimes, when we think about climate change, people of color don't come top of mind. So I just wanted to take a pause for a minute to say thank you to Matter and the School of Public Health for rising this issue to the top of our consciousness. Thank you very much. Nancy, something else that people may not necessarily associate with these issues is food insecurity. Generally speaking, can you talk to us a little bit about how food insecurity is related to climate change and health inequalities?
Well, I'm glad you asked me that. I'm not a statistics person, even though I love them, so I do have a couple stats written down, my little cheat sheet here. But just to set the stage a little bit, the industrial agriculture is responsible for about 14% of global greenhouse emissions, which directly creates and contributes to climate change. And food waste is responsible for about 8 to 10% of our global greenhouse emissions. And hospitals make up about 8.5, so a lot of numbers I'm throwing at you, 8.5% of our greenhouse emissions. So it's kind of a low-hanging fruit to address food security and the inequities and how it relates to climate change. The power of the power of hospitals is really to create more conversation and take some action around how to partner with local farms and get more equitable food into the system. What is equitable food? Meaning safer growing practices. So through regenerative agriculture and agroecology practices, it's actually reducing some of those industrial ag numbers of what the greenhouse gas emissions are. And with that, we see that communities are suffering, and we see that mostly BIPOC communities, Black, Indigenous, people of color, are in these marginalized communities that don't have access to healthy food. And hospitals can be that anchor institution to really bring in more resources for those individuals, create more opportunities both through supply chain, so their purchasing and procurement opportunities, but also through their community benefit programs, and really create either food bank programs or meal programs to give direct access to community members that might need it. So there's a lot of, I'll just stop there so that hopefully I just answered that question for you.
Thank you so much. So you mentioned hospitals as anchor institutions. Jaren, I'm curious, given your work, is there potential for other types of anchor institutions to help address some of these issues in your experience?
I think so, absolutely. I think that if we start asking what's going on in each community and which agencies and which buildings and which churches and which community activation is necessary, I think that in each community it looks different. And I think people have said it before, that we have to start talking to the patient, I think is what he said, but really talking to the people that are affected. One of the things that I have learned since I've been at IDPH is that people think we are top down, but we really want to bring everyone to the table, all the stakeholders to the table, and find out what works in one community may not be the same thing that works in the other community. So I think that asking the community what is available to them and who's willing to help is how we get additional anchors.
Thank you so much. It just makes me think of the adage, those who are closest to the issues are closest to the solutions. And as we all know, these issues are global in nature. It's not just a Chicagoland issue, right? So Andy, in listening to you present earlier, you touched on global issues as it relates to the topic. I'm wondering if you could drill down on specifically around the policies. Oftentimes, when we speak with community members, the go-to is we need to change policy, and we all agree with that. However, you alluded to some things that have to be considered before certain policies can be implemented effectively. Can you speak to that a little bit?
That's a great question. I'll give it a shot, but it is a complicated one. I think for me, one of the themes that I've been hearing all day is the importance of, what we sometimes at Rush, and not that Rush came up with it, but we say it at Rush, there's nothing about us without us. Understanding and working backwards from the lived experience, as well as the understanding of the challenges that are being faced locally, is critically important in moving any solution forward. That said, finding the ways to affect an existing structure. I mean, when I think about policy solutions, if we look at the current structure and the current structure is problematic, and if we're talking about a power structure, asking or pleading for the individuals, the institutions that have concentrated the power to voluntarily say, okay, yeah, we had our chance at bat and let's move on, is at best it's going to be a much longer term approach than I think any of us want. And so, policy from the perspective of, okay, the rules need to change. I'm a believer in markets when they're structured the right way. Right now, I think the markets are not. And to say, okay, these are the rules, and here's what we're trying to get at, that's sort of that last slide of changing what it means to win, changing that end state, to me is an important part of, kind of why I come back to the policy piece.
Thank you for that. And if I could stick with you for a minute, I want to drill down a little bit on this notion of a focus on well-being, which is relatively new. In my experience, I have a counseling background, the cousin of psychology, and we've been talking about that for quite some time. If we're serious about this notion of working with people, because there are people behind the numbers, as we know, and sometimes forget, unfortunately. When we think about well-being, what are some policy ideas that are being discussed behind the scenes, given your work, that may not have made its way out into the public? Just some ideas around how you're discovering how to measure this in ways that relate to the topic at hand.
That's a great question. I think, to put this on the longer trajectory, and speaking a bit more about what I'm hearing outside of the United States right now versus inside. By the way, I bash the U.S. a little bit sometimes, and it's maybe a little bit unfair. Some of it's deserved. The United States for the healthcare sector, I think, is ahead of some other developed countries out there in terms of the focus on social determinants and what can the health systems do around inequities as to be part of the solution. We're behind the rest of the world in terms of environmental sustainability, but this is the opportunity we have to learn from each other. In other countries, there's much more open skepticism about gross domestic product, or the economic indicators being the primary driver of what we consider success. And I think an increase in this push towards saying, okay, well, this is one way of measuring progress, but it needs to be in the context of, is this rising all boats? Is everybody better off? Or, to put a finer point on it, the most disenfranchised, the most underinvested individuals and communities, how are they doing? And if they're doing better, then we're all doing better. That's sort of the awakening that I feel like I'm starting to see. Even the economists, some of them are starting to say, I think we've lost our way a little bit. Because economics is supposed to be about making people's lives better. And somewhere in the math, that sometimes has gotten lost over decades or centuries.
Tell us about it. So I thank you for that. And Nancy, I'd like to pivot to you, and again, centering the most marginalized communities and individuals who live in those communities, and food insecurity. Can you give some specific examples of climate-related health disparities that exist in the greater Chicagoland area or urban areas like it?
Well, I am not from Chicago, but I'm actually from the Philadelphia area. But I will say that, before I answer that question, I just want to comment on Andy's response of sort of lifting all boats and sort of just recognizing that the way our systems operate is exactly designed the way that it was meant to operate. So it's not that something necessarily got lost in translation, it's that it was positioned so that specific people succeeded and had power and privilege, and other people, to be frank, people of color, and especially in this country, Black people, don't have that positional power or privilege. So I think we got to start there a little bit when we're addressing food insecurity and what hospitals can do, and sort of what the motives of anchor institutions, not just within healthcare, but across the board and across sectors, just to come to that reality, because I don't know if everyone's on that page, to be honest. And I think that's a huge piece that's lacking in the conversation often. Not in this room today, which is refreshing.
Can I
Please,
add to
please.
that? So I actually am from Chicago. Not that that's a slight. It's not. Although, I know. I'm a South Sider born and raised. We then moved to the suburbs. So, okay. And then I came back to work for another agency in a previous life, by which I would say we did some studies around in the Chicago area, places that would be considered food deserts. And there was a correlation between all types of illnesses that we know in marginalized populations and lack of the ability to have produce and or meat. So they determined that a food desert would be places where you didn't have, the option to buy fresh produce or meat. And a lot of initiatives went around trying to figure out how to put produce in those deserts. So I think that there is a space for that, and I think people are doing it. I think it's happening, but not on the scale that it needs to, because we haven't addressed the issue.
So thinking about history, as Nancy mentioned, there's a reason why we're not addressing these issues, or if we are at the surface level at this point in time. I'd like to pivot to a brief, if we want to even call it a conversation, the 30-second chat that you and I had before the panel, where you mentioned the salience of insects in relation to the subject matter at hand. Can you please speak to that? Because I was blown away in 30 seconds by you.
That's so interesting. So a part of what happens in my wheelhouse is that we give grants to local governmental agencies, including health departments that do mosquito surveillance. And because of the change in the environment and the summer that we've had and the past summers, the amount of vectors has increased. And a vector is just a mosquito that carries disease. So the most common one that we talk about often is West Nile virus. And the West Nile virus numbers for this past summer were at the epidemic rate. They were level to 2012 when we first started talking about West Nile virus. And that really has to do with the climate change and the environment being such that these particular mosquitoes grow. Additionally, the other thing that's happening because of the climate change is we're seeing more ticks that we hadn't seen before, so more tick-borne illnesses as well, so like Lyme disease, et cetera. So also, the Black and brown people are the people that are affected by these diseases as well, for several reasons, but when you are in the Chicago area, it's West Nile virus. When you are in the other parts of the state, you see an increased number of tick-borne illnesses.
Because I'm so fascinated by this idea, I'm going to drill down a little bit. I'm curious, let's say we were to promote this phenomenon more broadly. I'm curious about what exactly individuals and communities at large could do about it. Like, what are some potential solutions?
So that's challenging because we can't stop mosquitoes from growing, but what we can do is eliminate where they grow. So we would address the environment itself, but eliminating all water sources, that's a challenge. Of stagnant water is a challenge. So we do work with communities to do that. We try to figure out where the stagnant water is. We apply larvicide, not we, them, they apply larvicide. Communities, boots on the ground, apply larvicide to try to keep mosquitoes from growing in the first place. So there are efforts that are happening, but clearly not to the scale that needs to happen to reduce disease.
Thank you. Andy, I'm going to come to you now. You spoke a little bit on a very high level about some of the countries around the globe and things that they're doing to achieve, at least make progress as it relates to climate change and health inequities. Can you zero in on one specific example? And is there anything that we can learn from them in the U.S.?
One specific example, I tend to go vague on my answers. I'm realizing this now. Thank you for the insight, counselor. if it's okay, I might broaden this one slightly
Sure, please.
and mention the French Development Agency did a session at this World Hospital Congress a couple of weeks ago that was focused on green universal health care. And so it was geared towards low and middle income countries. And the goal was, essentially what we don't want is for these countries to adopt the Western style of high carbon intensive healthcare, because it's not scalable. It's not going to work with where we're trying to go. And out of that conversation, which was surprising to me, there were a number of individuals from developed countries that came because they wanted to learn from these other countries what their plans were, what their strategies, what their successes were in terms of delivering low-carbon healthcare. I don't want to steal thunder from what I imagine is coming from the next panel. However, I do want to say there's a significant focus on how do we make sure as healthcare needs expand. And if you look at 2050 as a goal, there's a real risk if we don't do anything in healthcare that the healthcare's carbon footprint just organically triples. So we need to shrink that back. So I think where we can really learn from each other is on the preventative side, and how do we keep people healthy in the first place? How do we address some of these inequities so they don't turn into needs for healthcare in the first place?
Thank you. And that now I want to come to you, Nancy, and I'm thinking about similar question, but more on the micro level. Oftentimes when we talk about these, again, these very complex issues, people feel as though there's nothing that they can do. There's nothing within their control, which obviously robs them of the potential to even make incremental changes in their local communities. So given your background and the work that you do, have you seen any success amongst communities as it relates to addressing food insecurity and its impact as it relates to health inequalities?
Yeah, it's a great question. And I was just chatting with somebody kind of along the same lines of this question where, of course, there is individual impact. We all have agency to do something. And as the last panel talked about, we all encourage it. Do something. But I feel like the emphasis really is on the individual. It's a part of the culture that we all swim in, where we all have to be very individualized and very specialized and experts in something. And to try to dismantle that a little bit is an important thing and put it back on the system, right? Like systems are made up of people, so we have to, and relationships, so we have to acknowledge that and really, own it and foster those relationships. But the system, and in this case, I'll talk about healthcare systems, really have a lot of power to do something to change the way that we're currently operating. So I would say as a community, the biggest impact is to try to get into those systems, in a way where you can partner with them and vice versa. And that's part of our work at Healthcare Without Harm, is really connecting the community members where anchor institutions are situated to those that are in decision-making roles, so that there can be some power sharing. And I think ultimately that's a key to solving some of these inequities, is to share power.
And Jaren, given your role, some could argue that you are part of the system. Okay, all right. So given that, have you seen community members successfully push you, i.e. the system, in ways that we might be able to take some lessons from and implement ourselves?
Absolutely, except I didn't need to be pushed. So in the food area, we work with Health Alliance, who I will say pushed IDPH in our food program to really figure out how to take people who are cottage foods entrepreneurs. Does everybody know what cottage food means? Cottage food is people who prepare food in their home for sale to the public, following rules and guidelines to help ensure that people don't become ill, because that's important to me. But how they then upscale. So then the next thing would be they could move to an incubator kitchen where they could upscale and then provide food to a greater group of people, or maybe even wholesale. So what we have done is really work with those stakeholders, and it was a challenge, and it took 2 years for us to have a standard operating procedure and guidelines for safety reasons. But what it has done is allow those people who have been cooking in their homes and maybe unsafely to now have a way that they can in their communities, because there are certain communities that have specific types of food that they like to get from specific people, so that they have a way to do that in a way that's going to be safe and part of the system.
Thank you so much. You know, by virtue of Parkinson being a co-sponsor for this event, it's not, difficult to understand that universities are, one could not even say argue, but one could contend, are part of the solution as well as an anchor institution. At IRJ, the Institute for Racial Justice, we like to think that we're doing higher ed differently, trying to focus on community impact in ways that go beyond measuring the time spent in a community. What exactly are we doing? Based on, and this may be cheating for you a little bit given where you work, and but I'll still ask you, based on all of your experiences, have you seen tangible efforts by university in support of your work? And in addition to that, what would you like to see as we move forward in your work? Maybe we'll come to you. We'll start with you, Andy.
Okay. I don't mind a softball. Okay. I don't. So we had a conversation about this during lunch, the role of the students as the lifeblood of universities, why universities exist, why they get funding. If students raise an issue or they raise a concern, it resonates in a much different way than tenured faculty like myself. People are used to me kind of spouting opinions. They, they know how to contain that. But a group of students raises a concern, and it's very different. I would like to give a shout out in case anybody on the online is a part of this group, but Rush and Loyola and Chicago Medicine and Northwestern, all 4 institutions, medical students participated in this initiative called the Planetary Health Report Card last year. Loyola, I think, was the first medical school in Chicago to participate. It's all over the world now. I think there's like 80 or so different medical schools that participate. It puts out a publicly facing report card on how the medical school is doing, curriculum, campus, all these different kinds of things. And the leadership pays attention to these things. The students in Chicago took this one step further last year, and they brought folks together to have a conversation across the universities to see what might we learn from each other. They invited senior leadership to attend as well, and it really hit them in a different way. So I feel, as an old guy, always mixed feelings about putting more on the next generation to fix this problem that the generation before me put on me to fix, and I didn't. But it really is, I think it's a source of tremendous energy and tremendous hope that the universities can bring.
Thank you. How about you, John?
So at the ID Page, we partner in many ways with universities, especially state universities, but specifically in the Office of Health Protection, we really work with the universities around our vector control program, as I was talking about earlier, because they do a lot of our lab work for us, and then they provide a wealth of data, so much data that we don't know what to do with it all. So we have epidemiologists who are great, and we still have too much data to try to make sense of, to make it data that we can use in a way that is going to make a difference, because that's important. We want to have informed decision making, so the universities also help us sift through all the data sources that we have. So they have been instrumental in providing us with information to make good decisions.
Thank you.
So I'm going to answer but expand from universities to include hospitals and other anchor institutions. And there are some strategies within these large institutions that can really make a big difference, and it seems like low-hanging fruit. So one is we have a Plant Future Forward, I always do that, initiative, which is really looking at menuing within an institution and trying to reduce the meat consumption on that menu. So replacing, and Rush is a big leader on this work. We invite hospitals to look at their menus to reduce the meat and maybe replace meat with another option, a plant-based option. So for instance, I'll use an example of at Rush, they had a plant-based meatloaf, which was delicious, where they substituted the half of the meat with mushrooms. And it's just an easy solution there. Another option for institutions is to look at how they're purchasing food and within their procurement. So we recently partnered with other organizations, the Center for Good Food Purchasing, as well as Real Food Generation, which works directly with universities to align our standards and how these institutions are purchasing food. So with that, we just released a new healthcare standard on guidance on how hospitals can purchase food that are aligned with certain values. So really valuing workforce and making sure it's an equitable, fair workforce, looking at local economies and supporting local economies in how you're purchasing your food, environmental sustainability, animal welfare is another value that upholds in these standards. So these are just a couple ways that anchors can partner to really kind of take some low-hanging fruit and make some easy options and changing how they're purchasing, how they're menuing, and how they're partnering with communities to do that.
Thank you so much. Now we're going to pivot from two questions from the audience as well as out there in the world at large. First, community organizers have been using the term food apartheid instead of food desert. The reasoning is that deserts are natural and not man-made. Are industry leaders adopting this term? What do you all think about this?
I guess I'll go first because I said food desert. And I'm old, so I'm going to go with the rest that I said food desert because that was the word I'm familiar with, but I am learning, and if there's a better word to use, I can adopt it.
So I'm pretty close to this because Karen Washington, who's a community organizer in New York City and community gardener, coined the term food apartheid. And she really spoke from experience in talking about that. And it kind of goes back to the point I made earlier around how our systems are designed to operate exactly how they're operating. So as you mentioned, deserts are natural. They exist in the world. It's not natural for communities not to have access to healthy food. It's not natural for fast food to be the only option in your community. It's not happening in every community where the only option is fast food. So that's why food apartheid is the term, because it really is an attack, essentially, on communities of color to cut them off from certain resources, as we're seeing.
Thank you. Going to go to this one. It seems like more and more healthcare institutions are focusing on profit over people. Do you have suggestions on how healthcare workers and academics can advocate against this shift? I guess that's, you're representing academia, so I'll start with you.
Yeah,
what can you do, Andy?
What can I do? There's a lot of, I mean, I think we're, how do I tease this one? So I wrote a book a couple of years ago, Healing Our Future, and in it I made the point that the U.S. healthcare system has been identified as unsustainable in the 1960s. And the trends that they had identified continue to this day. So we're all hoping the thing doesn't sustain, yet it still seems to keep sustaining. There's some big structural problems that I think need to be reckoned with that, I mean, I can't point to any individual and say, oh, you're the problem, you're a greedy CEO, you're a greedy physician, et cetera. They're all stuck within this system that really needs, I think, to be evolved beyond. I'm not going to defend the structure of the U.S. Healthcare system as it currently stands. I think the statistics out there speak for themselves. It's more expensive than any other health system in the world, yet it's not delivering the health outcomes that many other countries are seeing. I think what we need to start doing is taking a closer look at, well, what are we trying to accomplish with the health system? What are the models out there that might get us there in a different way? And to get louder and angrier about it, because it's not serving a lot of people in this country, and it needs to.
Thank you. Anyone else want to speak to that?
Can you repeat the question?
Sure. Yeah. It seems like more and more healthcare institutions are focusing on profit over people. Do you have suggestions on how healthcare workers and academics can advocate against this shift?
It's a big question. I don't think I have good answers to it, to be honest. I think power in numbers. That's what I'll sort of land on. You know, and it kind of goes back to our last panel and what they were talking about of connecting with people. And I think I'm a huge believer that we are based in relationships, that our world operates on relationships and who we know, for better or for worse. So I think when it comes to advocacy and organizing, that's the base of it. It's about who you know, how you're reaching those in decision-making roles, and how you're leveraging, you know, those relationships for a greater cause, you know, that's beyond yourself, ultimately, in an ideal world. Yeah.
Thank you. Here's another. Are there efforts by IDPH, Rush, Loyola, Healthcare Without Harm, or other organizations to build a community resource navigator for food access, healthcare services, and even opportunities to engage with other community stakeholders? So it seems like they're asking about tech and its potential to address some of the issues we've been discussing on the panel.
That's a huge question too, so I'm trying to wrap my head around all of the answers to that. IDPH does work with stakeholders. We, in my particular area, we work with whomever comes to us. So if an organization comes to us and they have an idea, we try to vet through it to see if it's something that is possible. Can we do it? We don't just say no. And I know people often think, oh, I go to the government and the government says no. But we really try to meet people where they are and then move forward. And we have also used a lot of technology to help us do that. And so we're reaching people through technology. We're new at it. We've had to bring in young people that understand it and that can move us forward in that space, but we're making strides. So I do think that there is the opportunity for movement and working together.
Yeah, I'm not a tech person, so I am not creating anything. But I will say, you know, it's a great idea and something I'm going to think about more. But we work nationally and globally, and these issues are different, even though there are similarities within each community across the country and potentially globally, how they play out is really different. So we actually, on our food team, really tried to get into a community, working with the community partners that are on the ground there to partner with their anchor institutions so that we're not necessarily the ones telling people what to do, but really it's informed by those that are affected by it and living there. So I think it would be a huge undertaking to create something like that, but one to consider.
Thank you. Another question. One of the challenges with food insecurity / food as medicine programs is that they are stuck in pilot mode. Does IDPH or others have any thoughts on how to scale / spread successful work?
So I don't know why it's stuck in pilot mode. And I'm going to say I've seen that successfully happen. There are farmers markets and other small scale, maybe not large scale, so maybe that's what they mean, but small scale operations that are using food as medicine, that have one of the words that I don't like to say, which is tinctures, they, so food is medicine, because I saw people look and they, what does that mean? So herbs is medicine, but these are safe herbs. They have been proven safe so that they're allowed for human consumption. So I think it's happening, probably not on a grand scale, but it is happening.
I mean, I can say that food as medicine programming happens within hospitals. It also looks like VeggieRx programs, so prescription programs where doctors are prescribing vegetables instead of medication in some cases, and also medically tailored meals. So those with chronic illnesses might need a specialized diet, and there are programs that create those meals. The federal government is pouring a lot of money into food as medicine programming right now, and they're also looking for it to be approved as a benefit through CMS. So there's been great strides on a national level, I think, and I think locally, oftentimes we do see things get stuck in a pilot mode, and I think it is challenging to scale on a national level. But I think there are benefits to that, even though it's not necessarily where we want it to go. I think every movement is a progress towards the ultimate goal.
Thank you. Should responsibility for carbon output be shouldered by hospital suppliers rather than the hospital itself? Opinions matter. Thoughts, ideas.
Great question. Earlier today, we heard, I think, several times, this is an all-hands problem. So I do think it's a both and. If you look at the carbon emissions that are attributable in the US to healthcare, I think it's like, I have to look at my colleagues here, it's like 75% is what's called scope 3, or it's the stuff that finds its way into the healthcare system because it's needed for the delivery of care, but it's not the energy that the system itself is using. So there's this huge area of need. Flip side of that, it's a huge opportunity. Healthcare is the sector that is focused by mission on health. We heard from Elaine at the very beginning, climate change is a human health issue. It's the biggest human health issue we're facing. So to the extent that this, and looking at the United States where it's nearing 20% of gross domestic product, a big buyer, lots of opportunity in that set of purchases. The anchors is one side of it, but the other side of it is the leveraging to say, we're interested in environmentally friendlier products and services. And so we're going to preferentially look for those vendors who can deliver that, and we'll work with those organizations to make that happen. Huge, by the way, opportunity for entrepreneurs to look at those because it's all over we just haven't had that on our radar before to care about, and suddenly we care about it quite a lot. And so there's lots of opportunity to be pulling carbon out of the supply chain.
I'm just going to build off of this question here a little bit. And I'm curious to see if there are any examples of positive movement going in that direction of understanding the supply chain and supplier diversity and so on and so forth as you're speaking to. Are there individuals, hospitals or universities or other just anchor institutions that we can point to?
Another great question, and I describe us as pretty early innings in terms of, even the Healthcare Anchor Network, that as a movement, as an initiative, is relatively young. And actually, one of the things Healthcare Without Harm helped us at Rush do is start to think not within the silo of community and the separate silo of environment, but how do we look for that intersectionality where we can multi-solve, as it's sometimes called. Elizabeth Sowen, I think, coined that term. And can we stand up, or can we help local vendors, BIPOC vendors, to provide goods and services that are environmentally friendly? And if we can if we can put the right resources into that, then we're solving multiple challenges at the same time. I wouldn't say I can point to any organizations that are far along that journey. In the United States, I think Kaiser Permanente is probably the organization that's done the most so far in this space. But it's definitely something we all need to be looking at.
Multi-solve, you say?
Multi-solving.
Multi-solve.
Elizabeth Sowen. I didn't come up with it, but I use the term all the time.
I would just add that Vermont Medical Center is actually a great example of an anchor institution that is kind of putting the money where their mouth is. Yeah, that is the saying, money where the mouth is. And I think part of that is because in Vermont, like, it's a good agricultural state too. So it's looking at sort of where the agriculture is and kind of speaking to like where the hospitals are placed at those political determinants of health, and it's the same with farmland too, and where in proximity are farms to hospitals. So then it's a shorter supply chain, and that's ultimately what we want to create. I mean, the pandemic, what we found is that those that had developed regional supply chains or regional food systems did better. The hospitals did better at getting food in because our global supply chains broke down during the pandemic. So it's just another added benefit there. When we see increased climate disasters, we want shorter supply chains so that we can actually have access to food and the resources that we need.
Thank you. Let's see. Chicago has appeared to have a worsening flooding issue. Do you think that this is also contributing to the stagnant water sources that allow West Nile mosquitoes to grow?
Yes, but I don't necessarily know that Chicago is the worst of flooding in the state. But I do say that there's a lot of flooding that happens, and in places where there is stagnant water, flooding does contribute.
Thank you. Maybe we can squeeze in one more. I'm not going to look at the. Okay. There seems to be an inequality in the quality of food that is provided to lower income schools and hospitals. Are there policies and structures that exist to help promote more equality of the ingredients provided to different sites?
I mean, it's similar to what I was saying before around the good food purchasing program and the healthy food and healthcare standards. So the quality control is really in sort of the upstream effects of how food is being grown and produced and processed. And with that, we support smaller entities, local farms that practice regenerative practices that really nourish and put nutrients back into the soil, so then the food is healthier, has more nutrients as it grows, and then has better processing and shelf life for when it's actually needed to be eaten. So it kind of goes back to that shorter supply chain. If we are investing in those practices and the farms that are doing healthier practices that are better for our environment, creating smaller and shorter supply chains, we don't need to shelf food for months at a time. It can just be consumed and then be on a healthier cycle.
And then I was just going to add, was the question policy? Was that the beginning part of the question? Is there policy around?
Sure.
Or, no, I wanted to know. I was going to say there's laws around it. So across the board, there is a minimum standard of what has to be provided in student lunches. There is some space for each school district to purchase according to, as you just said, but there are some minimum standards that are required, yes.
I'm going to squeeze in one more because it's directed right at you, Jaren. Yeah, for Jaren. Thank you for highlighting the other environmental issues such as lead abatement, toxicology. How do you address and balance the false dichotomy that is being created, highlighting climate over other issues?
Wow.
I'm sorry, I set you up.
I know. Okay. So I don't necessarily think that I am highlighting climate over other issues. I think that it's all interrelated. I think that we have a lot of health disparities happening because of the climate, but we also have these things in toxicology, and we also have these things in lead, and we're still doing those things. So I didn't come today to talk about children with high blood lead levels, but we're still doing that work in that arena. I didn't talk about toxicology, but we're still responding to PFAS in our environment. So I think all of the things are happening at the same time.
thank you. And I think that that's a great way to end today's panel. Really appreciate all of the information you shared. I learned a lot, and I'm sure that the audience did as well. Thank you.
Thank you. I was reflecting on this, and when we come back from break, I was going to share a few thoughts, but this basic block and tackling of good health, trying to address health disparities, whether it be lead or whether it be physical activity or nutrition, still needs to keep going. And to some degree, it may be exacerbated by the conditions that are occurring in the environment, but the basic block and tackling and challenges we face in public health are still there. So I just want to thank. This was a very lively discussion, getting us think in different ways. We are now going to take another 15-minute break for those that are in the room and those that are online. We come back at 20 minutes after the hour, and we'll be watching a video of an entrepreneur who's trying to put into action actually addressing ideas of waste in the health system. In this case, the waste that's related to packaging with medicines as one contributor to address the overall problem. So we'll see you back in 15 minutes. We are getting ready to close with our last session. So I'll just give a minute for everyone to settle in. It's great to hear so much conversation going on in between the break. So if we can have attention again. I always feel like in the front of the classroom, you should maybe, kindergarten. Okay, guys. I just have to speak louder. Thank you. All right. I think the energy is great. The dialogue that's great. It shows people are very engaged. And we know that when we bring people together that are already focused or concerned about environment and health equity, good things can happen. So this last session is going to be bringing it home in terms of, what can healthcare systems specifically do. But I wanted to just share a few reflections of, again, bringing it back to the entrepreneurial spirit of what I heard a little bit, or things that we might want to carry forward. One is, it was emphasized in the prior panel also, as find your climate story, right? How we tell the value of the why is essential in terms of motivating. And what I was really struck at listening is this is the classic challenge in public health. Please do some action now for some future benefit. Please eat your fruits and vegetables now so that you don't get cancer 30 years from now. Or please make sure you do your physical activity now so you don't have heart disease or diabetes 20 years from now. And so this already is a challenge, right? Is how do you make that future state, where are you in? Yeah, that future state relevant for today such that people take action today. And in public health, we often talk about upstream determinants of health. That's the social determinants of where you live, your education, your religion, access to good, clean air, where you live, the physical environment. And those upstream determinants take a lot longer to affect and therefore see the downstream benefits, right? They're intergenerational. So that's a layer to think about. How is the climate affecting things that have long-standing trajectory already, and it's amplifying it. So we heard a little bit of discussion around food insecurity or access to good food. But then there's also the downstream effects, I think, of climate, and that's the exacerbation that's causing immediate need for health care access, like we heard about asthma, for example, or other areas in which you could say mental health, right? The strain of that is happening immediately now. And the downstream determinants of access is now, are people getting screened? Are they getting the services? Are the services affordable and accessible? And so I just was reflecting, as we think about telling the climate health equity story, making those connections relevant, because folks might not realize the West Nile virus that they have is actually a downstream effect of a lot of things that do relate to already problems with freestanding water, but exacerbated by the climate events that are happening. So part of our challenge is telling that story simply. And we can learn from, I think, the entrepreneur community. How do companies sell their stuff? They try to make it complex down to very simple things that motivate us to buy things. The other thing I took away, and I don't have an answer to this, but when you think about entrepreneurs and startups, and the video we're showing next is actually someone in that phase, we know that there's seed funding. So they'll talk about Series A, I'm at Series B, C, whatever. There's a sequence by which they go from idea to pilot to demonstration, proof of concept, and further dollars to scale. We really don't have those easy market funding mechanisms for public health or healthcare quality improvement types of innovation. And I wonder if that might be, how do you financially create those environments of investment? We have a complicated US system of federal funding, state and local. And so it requires navigation at multiple governmental levels, much less private sector levels. So as we think about the accelerating translation, how might we make it easier for things that we see are working that are addressing CO2 emissions or climate-related things so that they rapidly scale across the US? And then the last one I took away is we always talk about this in, as I was sharing earlier, the value proposition statement. They'll talk about who's that first target customer where you can get traction, where there's high energy and interest in it. And they become your beachhead market, so to speak. And I wonder if we should be directing more energy towards students, and students as customers, but students as voice, students as activism, and how we also, by being active is a sense of giving hope, and how that might address that. The other area is, and this will lead into our next talk, the power of hospitals or health systems. And in many places, I came from a state that, in Colorado, that had a very large rural health system. And so the hospitals are the economic workforce of that community. They're an economic driver as to who they hire, as well as how things get paid. But they also bring that social capital force. They're often leaders in boards of health and local community, and therefore have influence. So we heard themes about how we do basic procurement, how we buy, how we do HR, how we hire, how do we consider these factors in that. The healthcare systems have a lot of influence. And then we heard from you, Andy, the leverage of who they procure with. And that is powerful as well. So if others are realizing that this is important to show in order to get those contracts, that has effects. So let's look right now. How many of you are buying clothing right now because they're talking about the environmental impact of the clothing, how they're manufacturing it, or they're using renewable, they're recycling the fibers, et cetera. So that's influencing how I buy now, right? I've noticed, I know our government spokesperson, speaker didn't talk about companies, but I'm noticing that United is putting on their app when I'm purchasing how much CO2 is going with which flights and which ones are the low CO2 flights, right? What if we were to imagine healthcare systems, in their report carding doing that and now making this a benefit that, it influences how purchasing is happening. So those were some things I took away. I think we'll have much more detailed discussion around with our next panel around thinking about it now in the healthcare system as a CO2 emitter itself. But we wanted to kick it off. This is also in the afternoon. People are probably lagging a bit with a fun video. Last year, we sponsored a more traditional pitch competition. A lot of times when a company or an anchor institute like a university wants to catalyze innovation in an area, they might say, we'll sponsor a pitch competition. So last year we did, it was on the intersection of health equity as well as climate and products. What we learned was there's not so much startup community in the US region. A lot of the innovation is occurring outside of the US. And a lot of it requires much broader cross-sectoral partnership, which is what led to the forum for today. But we wanted to give you a glimpse of, because it's inspiring, I think. Here's a young entrepreneur that's trying to address this problem in a way that is also something that's commercially scalable and viable. So we'll just cue now to the video. It's a couple minutes long.
Hi, my name is Melinda Lee, and I'm one of the co-founders at Parcel Health. Parcel Health is on a mission to replace plastic packaging in the healthcare system. Our flagship product is the Fillbox. It is a fully recyclable and biodegradable alternative to plastic pill bottles. It is water resistant, humidity resistant, and also light proof when it is fully closed. In an independently conducted life cycle analysis, throughout its life cycle, the Fillbox emits 72% less CO2 equivalent emissions and also requires 75% less energy to produce and use throughout its life cycle compared to plastic pill bottles. At scale, this is equivalent to about removing 89,000 cars off of American roads. The Fillbox has been adopted by 37 pharmacies in the US and Canada, and it continues to pique interest from pharmaceutical companies and also large chain pharmacies in the US and abroad. Since winning the pitch competition, we have gone on to raise a pre-seed round of $500,000. We have launched our pilot with University of Michigan. We have also exported to Canada, and we also expanded our fulfillment facility here in Pittsburgh. We are really, really grateful to have had the opportunity to pitch last year at the Loyola University Health Equity Quest. We're also really, really grateful for the mentorship, the financial grant, and also the recognition that came with the Loyola University Health Equity Quest. In the next 6 to 12 months, we are really focused on adding new sales and distribution channels for the Fillbox so that we can get it to more pharmacies. We're also working really hard to scale our team here in order to bring our product to market. We love the community at Matter and the advice that we've been getting this past year being part of Matter. I'm happy to connect with anyone in attendance. My contact information is here, and feel free to reach out. We're always very happy to talk more about our product and our vision, and in general, just expand our network.
Working with Matter because it's an opportunity, as we were talking in the last panel, to be an anchor institute and hopefully raise to the agenda, stimulate, and help weave together the ecosystem to work on this. So our next panel and concluding panel is looking at how might we approach reducing healthcare's carbon footprint. And we will follow a similar format in terms of a mini keynote that might be re-energizing, from what I understand, and that is Dr. Peter Ortiz. He is a professor and senior physician of occupational medicine at the University of Illinois at Chicago, but he's also the executive committee member for the Illinois Clinicians for Climate Action. So earlier we said ask patient, but now it's an opportunity to ask doctor around, what can we also be doing in our healthcare systems?
Do I use that? Okay. Afternoon. I'm going to tell you a story. It's not going to be my full 10 minutes, so I'm just going to hit a couple of points. And this story, as with all good stories, begins in Windsor, Ontario, 1994, and a guy comes in the bar after a meeting we've been in all day and says, "Do you know what the EPA said today? The EPA announced today that the healthcare sector in the US, and hospitals specifically, were the top polluter with dioxins in the country." Now, those of you who are too young don't remember dioxins as coming from Agent Orange. That was a pesticide used in Vietnam, a herbicide used in Vietnam, and there was a lot of activity about that in the 1970s. But by early 1990s, there was considerably less going on with respect to that. So suddenly, though, this began to turn lights on about how to reach the general population about some of these more hidden hazards. Now, oh, you've already got it up. All right. Oh, that was me pushing the button over here. I'm in trouble. Don't look at the slides yet. No, wrong way. That's not mine. I was told, just push the button. Can you get me to start? Screwed it up already. Sorry about this. All right, now what do I do? Just push
The arrow.
in the middle. All right. Okay, so one of the reasons now somebody's playing with me in the back. I can tell that right away. One of the reasons to talk about healthcare and its contribution to environmental degradation in general, but more specifically today, to its contribution with respect to climate change is what I'm looking at back here. And that is a slightly different numbers than we've had before, and we were always talking about before, where the best estimate we could come to was about, I don't know, 6-8% of greenhouse gases came out of the health sector. But it turns out that that ignored the supply chain and ignored the production of everything that goes into what we provide in healthcare. So when you take all of that into account, and this is a 2021 analysis, about 70% of the greenhouse gas burden, if you will, coming out of healthcare comes from that supply chain. So when we're talking about it now, we've got over here on the right, the United States, about 27% of that greenhouse gas emissions are coming from healthcare. Makes sense. We have a rather energy-heavy sector. We've got a huge sector in the country. So that probably is a better estimate now. And as you look around the board, you will see that the major polluting countries with respect to greenhouse gases all have a contribution from healthcare. So the first question is as to the why we're contributing to the problem. Next thing is the sector as a whole has a moral imperative that says do no harm. We should not be poisoning our patients in the general community just because we're taking great care of them when they get into the hospital. We should be preventing those problems, and we should be avoiding doing harm if we have a way of doing so. And this is just a footprint in what goes into the greenhouse gas burden, again, from healthcare. And one more reason before I leave these slides, and I'll come back to them, is healthcare is almost universal on a global level. And in fact, while it varies between what the hospitals look like and where the most care is given, the process of giving health care is just about the same everywhere, and just about the same with respect to training and the provision of care to individuals throughout the world. Individuals come to the healthcare providers, they sit in some kind of a setting, they do some kinds of testing, they take a history, they do a physical, and then they give advice to the patients, etc. Similar all over the world. And in fact, the training of physicians and training of particular healthcare workers, such as nurses, etc., is very similar throughout the world. So you would think that there was a way of reaching everybody with the same kind of educational paradigm. And just calculating as well what's going on in the healthcare sector, it's exploding all over the world as well. So we're in 1948 here. We've only got about 3% of the gross national product globally. In 2003, 10%. And today it varies between 2 and 14%, controlled frequently by the economics of the country or the government as a major purchaser. The next thing we knew came out of the 1960s, 50s and 60s, but primarily 60s. And that was healthcare professionals are influential opinion setters, and despite COVID-19, still influential opinion setters, especially when they have changed their own behavior. And we knew that from the civil rights movement, that when people were doing things that were contrary to their preconceived notions, such as integrating schools, when they said they would never send their kids to integrated schools. After that occurred, 3 years later, people had modified their opinions about it. And we knew on the reverse side, when doctors and nurses stopped smoking, they started talking to their patients about it. And they had a tremendous influence on the general population. Didn't go down as much as we would have hoped, but it went down precipitously in a great deal. So all of these reasons told us not only why healthcare, but told us a little bit of how to try to reach out and move the sector as a whole. And that was not just a question of moving the public health docs, not just a question of moving the few environmental health docs around the world. It was a question of moving the clinicians in that individual interaction, as well as in their role as planning those interactions in governing how hospitals were organized and healthcare systems as a whole. And it was universal. You could have a private healthcare system like the US predominantly with private insurance, or you could have an entirely public healthcare sector and many countries around the world. And the process of reaching the members of that sector were about the same. So that's where I'm going to stop just at the beginning here and turn it back to my co-panelists and then the questions.
So we invite the panelists up to the front. And a reminder for those, again, who we will have panel discussion. And if you have questions along the way, matter.social.qa.com, and we'll have the Q&A at the end. So hand the baton to you. This panel will be led by Dr. Nancy Tuckman. She's the founding dean for Loyola School of Environment and Sustainability. And we've had the pleasure of working with that school in a number of interactions. And I'm glad that we get to continue the dialogue on this very important topic. Thank you, Nancy.
Thank you, Elaine. And thank you, Matter, for hosting this. It's always great to work with you. We're happy that you're very connected now to Loyola University Chicago. This issue of climate change, and if I can kind of even expand it to just the degradation of the environment in general, there are several sectors in our economy that contribute hugely to environmental degradation. And we know about agriculture, we know about transportation, we know about industry, and also healthcare. But we're going to focus on healthcare. And I would like to start by asking the panelists to introduce yourselves, please, and then answer the question, what do you think, in what ways do you think healthcare is contributing to the degradation of the environment, including climate change? Would you start, Geneva?
Sure. My name is Geneva Brown. Thank you all for having me. I'm currently the global head of ESG and DE&I for the Cigna Group. So as part of my role at Cigna, I focus on ESG, environmental, social, and governance, as well as diversity, equity, inclusion, and belonging. As part of that, I think a lot about sustainability, environmental justice, and how overall what we do and who we are as a company, as well as our touch points with our communities and our clients and care teams, how that has an impact both internally and externally. So within our workforce, within our company, but also in all of the places that we work and where we touch. My background is as a practicing lawyer. So before I've been in this role, I actually did mission-driven healthcare deals, like mergers and acquisitions, as well as venture capital investments. And so have for years thought a lot about the healthcare ecosystem and how we do things differently. How can we use the work that we do to make a real sustainable impact? To your question about where we could be running afoul potentially in our industry, I really think that a lot of it has to do with sometimes not being intentionally thoughtful about some of our practices when it comes to who we need to innovate. At times we kind of default to, perhaps people who have the more traditional backgrounds or skills to do the work that we do, but we're at a point where we are dealing with unprecedented crises, and in order to deal with that, we need to have an unprecedented amount of innovation coming out of our company and other companies and organizations. So for that, trying to be really thoughtful about our hiring practices, being thoughtful about where we spend money, really knowing that the diversity, doing our work in a way that brings together different backgrounds, different leadership styles, different ways of thinking. If we're intentional about that, I think we could do a better job in ensuring that we're intentionally innovating in new ways and co-creating solutions.
Thank you, Geneva. Allison?
Good afternoon, everyone. Allison Hansen. I'm the CEO and Executive Director of the Illinois Medical Group. For those of you who don't know the Illinois Medical Group, we're 560 acres. Think of us as 1 square mile. It's where Rush is located, the University of Illinois, UI Health, Cook County, as well as Jesse Brown VA. We've got 2 universities within our 560 acres, and we also have over 40 different types of healthcare organizations that support our industry. And healthcare is so interesting. My background is healthcare. I spent 20 plus years working for hospitals in the Chicago area. And so now I feel like I'm outside of the box of the hospital, looking in and thinking about what we can do differently to support our community. We know that healthcare creates, and we've talked about it in the earlier panels, so much of the problem of what's happening, not only through medical gases and through products and production and distribution, but the transportation issue of bringing those to the healthcare industry is a big contributor. And so I'm excited to talk to you today about some of the things we're trying to do in the Illinois Medical District to change that. And it starts small, but it really starts with education.
Great, thank you. Peter, you've been introduced, but you want to answer the question what you think healthcare is contributing to climate change and environmental degradation.
So I'm Peter Horace from the University of Illinois. I think what we have in healthcare and the decision-making process at our larger institutions frequently has a higher acceptance of the status quo than we ought to be having. And one of the reasons for that is we are buffeted every day with new theories, new ideas about this and that we really do not, we really need to not accept without good scientific support for the development. So how do we move ahead and get an institution like a hospital decide to change approaches and reduce their carbon footprint? The first question is then to make an overture to the professionals in the hospital, each from their own professional backgrounds, based on rather conservative science. Now that's a bit of a straitjacket, because it means there's stuff that you can't really rely on because it's not generally accepted. You have to go through and use kinds of material and science from well-accepted sources and documentation. The next question is making the invisible visible to our colleagues, because the colleagues as a whole are dedicated to curing illness, preventing disease, etc. But there is a real invisible step between the kinds of things we're talking about environmentally, such as climate change, and real disease that they see in their office every day, or they see in their clinics every day. Now, because climate change is moving ahead, that big space there is becoming obvious to most of the world, let alone the healthcare professionals. But that's our first step. Yes, there's a direct link. Here's the science to demonstrate that. And then the key thing is, here's what you can do, or the institution can do, where you are, to reduce that burden. And when you do that, you will not be impacting negatively on patient care. So that's got to be a given. We will give the same quality of patient care, and we're going to take this new step to reduce our imprint in this way. So that was our next step in that process. And I should get the clicker for the next thing. But anyway, thank you.
Thank you. Yeah, and that kind of leads to the next question of what are some of the key challenges and barriers implementing sustainable practices in healthcare, and how can we overcome them? And can we start with you, Allison?
Yeah, I think some of the key challenges are just having people, to your point, really understand what's their role, what can they do. And so at the Illinois Medical District, you know, we're a commission. We oversee our geography, and we have the opportunity to be a convener for those that are residing in the district. So we have, if you think about, you know, a hub and a spoke, at the middle of our hub, we have an advisory board. That's the CEOs of our major anchor institutions, our hospitals and our universities. I apologize. This is my son calling from college. I'm sure he just needs the Amazon code to get in to order something. So, you know, and so we have a real opportunity with those advisors at the center of that hub to build councils that inform them on what do we need to do in the district to make our ecosystem sound. And we have 9 active councils, everything from arts to education, but a really critical one for us is a sustainability council. And the reason that you might decide to join that sustainability council is because maybe it's your role in your organization, but maybe it's your passion. Like maybe you just know it's what you're about and what you want to contribute, and it might not be what you do for a living, and you're welcomed. It's an inclusive council where people can come together, and we really believe that by leveraging those councils and having those conversations with our CEOs, we can begin to make the difference we need to make in the district.
Thank you. Peter? Yeah, back to you.
He's got slides.
No, I can't see it. All right.
What are the key challenges and barriers in implementing sustainable practices in healthcare, and how can they be overcome?
So, let me just give you a little shadow puppet for a few minutes. You're going to do it for me? Thank you. So in terms of making the invisible visible, okay. Next slide. Yes. So then the question becomes, what can you practically offer people to do within a hospital or an institutional setting? What can you offer the institution to do? And we used to go around and give lectures about, it's going to cost you a little more, but you really ought to be doing it for the environment and society, et cetera. Turned out that wasn't true. Turned out we went to Mexico and we discovered it was going to cost them less. We went to Cuba and they said it was going to cost them less. Now we said, well, the Cuban economy is kind of funny. There's only 10 million people here. We don't really understand that. Then we went to Manila, the same thing. Everybody told us when they organized these sustainability initiatives, it cost them less. And because most of the initiative was dependent on the organization and education of the workforce. So where could you impact? And if we're talking about waste anesthetic gases in the OR, the anesthesiologist said, hey, we've got stuff that does the same thing in terms of putting the patient to sleep, but from an environmental point of view, adds much less in terms of the greenhouse burden that we're contributing from our anesthetic gases, which turns out to be a heavy burden over and above what we talk about in terms of carbon dioxide and others. Most of the time, we always considered, well, we're just talking about heating the place up or cooling it down in terms of energy in general. And that's certainly a big aspect of it. But then when you start to build new hospitals, how big's the room? How much should it be? Can you open the windows? Can you see trees outside? All of these things now that come into the lead criteria for hospitals and the advice about in healthcare, exactly how do you want to build hospitals. And also, what we discovered in New York is we don't want to put our transformers in the basement anymore. Yeah, they're real heavy, but we don't want to put them in the basement, excuse me, because when the city floods, and we're seeing more floods, et cetera, your power gets knocked out entirely. So we really do have to go back and put those things on the roof. It's these kind of practical concerns that don't cost necessarily more, but are very important long term. And I guess that's it for that part.
Thank you. Yeah.
Yeah, okay, this is just tooting our own horn. About 10 years ago, we did a study about various kinds of interventions. And the most expensive ones were, in terms of initial investment, were the climate stuff, the greenhouse gas stuff. But even those, after a year and a half, 2 years, you were already making back on your initial investment. So Northwestern, I'm on the faculty of, was having a big fight about, with community groups in Evanston and also in the city about whether they should be paying taxes and whether they should be, I'm losing the words, allowed to pass on taxes because they were doing such good for the community. And one of the things we were going around telling them was, yeah, you want to use these changes to tell the tax folks that's what the good is you're doing for the community. Well, this killed it because it was clear that they were doing very well by making these changes. Anyway, that's just a small piece.
No, thank you. Thank you for that. Geneva, do you want to respond?
I think they covered it.
Okay. You know, I'm kind of interested in getting a little bit deeper into what are exactly the problems with the healthcare systems, with hospitals, things like the anesthetic gases that you were talking about. Desflurane, I think, is a very, very strong greenhouse gas, nitrous oxide. Both are used abundantly, but also what happens to the gas that's sort of left over, and yeah. Another thing, and I'll just have you talk about whatever of these that you're passionate about or know about, but the plastics, the single-use plastics, enormous amount of plastics coming out of hospitals because of the single-use, and other waste products as well, gowns and drapes and mattress pads and all that. I think also about the instruments that are made and laid out in an OR room that may or may not be used. Oftentimes, I know Australia is dealing with the problem where they're doing the mining of the iron ore, and they send that iron ore to China to be smelted, and then the smelted iron ore goes to the Philippines to be made into a tool that then goes back to Australia. So there's a lot of embedded materials and greenhouse gases, energy that are used to produce these things, and they're used one time and then thrown out, which, from my perspective is ridiculous, but I understand, the concern of contamination. Greenhouse gases is another one, water is another one, chemicals used in just cleaning products. All of these things are concerns that kind of buckets of sustainability, including food that we talked about in the last panel, that that any institution, not just hospitals, can work on and should be working on. But you know, from your perspectives and your experience, where do you think hospitals can make the biggest impact?
Well, I'll take that to start. I would say it's got to start from the top. It's got to be a passion project of the leadership. It can't just be talking points. It's got to be something that they're willing to invest in. And I love Dean Morales's suggestion earlier about, you know, we don't even put pricing in supply rooms. Staff don't know when they're pulling something down how long it took to get there, how much it costs, what kind of greenhouse emissions it might have contributed to. I mean, there just isn't the type of information to make good decisions when you're making those decisions in the moment. And as healthcare continues to expand, that's just going to become a critical ingredient. And somehow we have to align our finances and our incentives, just like we do with quality, with this particular issue if we're going to move it forward.
Yeah, and I would add to that, you know, starting from where you just left off, is like being really thoughtful about your spend, right? Like I don't work for a hospital, we're a health services company, so we have a pretty broad variety of products and services that we offer, but we are a big spender, right? So very often we're focused on how we drive our own revenue, but also we have to think about our expenses. And when we do that, right, look at your vendors and your suppliers as an extension of what you do, right? It might not be your own direct work, right, because they're outside of your organization, but you may have been able to select from a large, you know, pool of potential vendors. You pick the one that you picked, well, why? And there should be a sustainability question that's part of your why, right? I am intentionally selecting this person, and I understand how they contribute to climate change, how they're thoughtful about sustainability. Ask those questions, and you know, even be thoughtful. Should they go into your contract? Should you continue to track how they're doing? Are there metrics? Do you keep maintaining that relationship? Because I think that that's really important if you sort of take even your external relationships as an extension of your own organization, then you will really start to be able to move the needle.
Thank you.
And that's really important, both of them. But the last piece about how does an institution impact on the supply chain and how then the materials delivered to them, just as one single institution. Now, obviously, for Kaiser, you shake your muscles a bit and you're 500 hospitals and you can make some rather rapid changes. But for most of us, you're purchasing from large purchasing groups or you're purchasing from large vendors. And there's a culture built up there as well in terms of supplying what they know people will like, producing what they know people will like, and to feed into the preconceived notions. So as a physician, I spent 25 years doing general internal medicine at a county hospital, and there were a whole lot of things that we didn't even think about because we work in front of the proscenium. You know, the 7 waste chains from a hospital is something that I had never heard about doing medicine there in one way or another. But how did these things get purchased? How come we're purchasing single-use devices? And it's, as you say, because nobody is sitting on that committee saying, well, that's right, that's a very good thing. The cardiologist brings in the new device, says, I really like this. Maybe he hasn't even been detailed, okay? And he says, I really like this. I read about it. They're doing it in the East Coast. I'd love to try it here. This is a good thing. Nobody is sitting there that feels empowered to say to him, nobody before, now it's changing, to say to him or her, well, gee, that's nice. Are there any alternatives? What is the weight of this on the environment? What can you use that's the same thing in the same way? And you go back to the OR packages. That in many community hospitals, the OR package was determined by the particular surgeon in the particular way they did surgery and the particular concerns they had about running out of one thing or another, which they didn't want to run out, because these things were all prepackaged and then shipped to the hospital after being sterilized, and that's another thing we discovered. So but there was nobody saying to that surgeon, and sometimes it was even after that surgeon had retired, and well, we always did it this way, so we continued to do it this way. So the question then becomes to ask those questions at the point that they're making those decisions. And you don't even have to answer those questions. If you purely ask suppliers those questions, it's the old, you have a sniffle, they got a cold. They're going to go find out what they can do to avoid losing that contract in one way or another. What we discovered recently was about this ethylene oxide that turns out we use to sterilize almost everything that's not metal in healthcare. And it turns out ethylene oxide is one of our few known environmental causes of breast cancer. And we are discovering that the companies that were doing ethylene oxide sterilizing healthcare stuff, mostly were doing it outside the hospitals. Because way back 20 years ago, in the hospitals, we pointed out problems for them, so they stopped doing it in the hospital. So it was done in small communities, a very clean process. And just west of here, in the town that this blew up in a few years ago, right across the street from City Hall. And high levels of exposure and some clear documentation of the effect on the community, breast cancer and hematologic cancers, et cetera. So these things lead you one thing to another thing. It's an interesting process of how they got there and why they stay with it. I suppose I'll just take 2 seconds. The culture, that's what's so fascinating. You talk about entrepreneurship as a method of jogging the culture. The culture of production is, you take ethylene oxide. If you have a product that's plastic and you want to use it in healthcare, you have to demonstrate to the FDA that in a method of sterilization, you get a 6-log drop in the bugs on the product, right? And so, and then the FDA says, okay, that new product you can produce and sell with this approach to sterilization. Well, what happens is, you're an engineer working for J&J or something else. They come to you with a new product they want to sell, and they say, we really want to get this on the market. Well, you've got to be you're probably not working there anymore if you're saying this, but you don't want to turn around to them and say, well, we're going to try a new sterilizing process. It may take us a few months longer before we can get it certified, but we really want to do this one. No, you go ethylene oxide. So the culture itself moves in that direction. And we have to find ways, like entrepreneurs selling the alternatives, to shake up that culture some.
Yeah, I think, to the point of leadership in organizations, it's really important for healthcare organizations to bring in a high-level leader that's a sustainability director or a sustainability VP that can look at the entire organization, what their operations are, what their waste stream is, what their supply chain is, and really make accountable for all the products that are purchased, all the products that are used, stuff that isn't used but goes into the waste stream, et cetera. I think that's a really important first step for organizations to make, and it certainly isn't just the healthcare, but it's any kind of business or universities in our case as well. I also want to make the point that I think hospitals and healthcare organizations they're an enormous part of the economy, and if they purchase together, they could have huge power and put pressure on the Medlines and the J&Js and the organizations that are developing the materials that hospitals need to purchase, and think about making their things more sustainable, reusable. What do you think about that, Allison?
Yeah, I think it's a top-down and it's a bottom-up approach, right? You need to be able to apply the pressures as a big system, but also as a big system, do you think about shopping local, right? Or are you, driving and transporting goods because you've got one vendor that might not be located close to all your hospitals that you're purchasing from. So I think it does require either the leadership to have that appointed individual who's really making thoughtful decisions and really understands the data and what you're ordering, but it also requires innovative thinking. And I think earlier it was discussed about how the students play a part in that, and the next generation is going to play a part in that. And we see a lot of energy and a lot of passion from our community from that group. We use the UIC urban planning and policy making students to help tell us, what should we be doing different in the IMD? What would you like to see in the future? What kind of legacy do you want us to leave for you? And so I think it really requires both a top-down and a bottom-up approach.
Great. Geneva?
Yeah, I would agree. And I was just talking to a few people at lunch, right, where what I see happening at Cigna, which I think is great, is that we're bringing together people who may have the technical expertise. They may be able to be hyper-focused on the science and the engineering. And then you bring in someone like me, right, who has a lot of passion, who may have skills. They may be a recovering lawyer like I am, or from some other discipline, right, but has a skill set that knows how to drive things forward. You bring together people with these diverse working styles, these diverse leadership styles, and like you said, diverse in age, in background, right, and you do it in a way where you're bringing together groups of people who can really accelerate your mission. Like, I think mobilizing on some of these steps go beyond kind of the traditional silos where the clinical teams all work together. Right? You had a care team that only had people with a medical background, and I see a lot of our ESG work as an extension of those teams, has permanent seats at those tables so that we can provide strategic thought leadership when decisions are being made. I think is really important, because without that diversity of thinking, what ends up happening, right, is that you miss places where you could make an impact. Particularly if you think, I think to Alice's very good point about local environments, right? Like there, of course, if you're an organization, you may have customers and clients all over the world, but you can take that all over the world approach, but to make a real impact, you might also need to take a local approach too, and think about your emissions where you are. Think about how to make changes in local environments, how that impacts that particular community, because it may be different. Social determinants of health look different where I'm based in Philadelphia than they may look in some other geography, and I don't feel like we should get a pass, like, oh, well, because where we work, those communities are different, then we're off the hook because we can't speak to everyone. No, we can. It's hard, it's challenging, it's complicated, but we can do it, and part of the way that we do it is being thoughtful about bringing this inclusive group together where they know they can feel safe to take bold action.
And to riff off that for a second.
Yes.
In terms of the internal culture at our institutions that provide care, we are thankfully over the last several years making a transition over whether or not racism was an issue for the society as a whole versus every institution looking at, in healthcare, looking at what it does to overcome the inequities in healthcare, to overcome the implicit biases in how healthcare is provided, and viewing the overall healthcare product as needing to impact on the social determinants of disease in the community as well. With respect to the environment, that needs to be expanded so that, as you say, we need a driven CEO. And it's a driven CEO that understands that part of the product of your healthcare institution is the medical care given, the impact you have on the inequities in society, and finally, the question of sustainability. And they've got to integrate that into the evaluative process of their C-suite folks and as it goes down the line. And it's very simple. They don't have to make a big deal of that. If it just appears as part of the evaluation of executives in healthcare, it will have a chilling effect throughout the institution, which is one difficulty with voluntary green teams. Having chaired our voluntary green team at the U of I at the hospital for a while, I will tell you that we got a lot more powerful and a lot more involved when somebody was assigned to us as part of our activity and the leadership of the green team who was in the C-suite and was there advocating and solving these problems, et cetera.
All right, thank you. We have time for one more question that was designed previously, but then we're going to move into the questions that are coming from the audience and from the people that are joining us online. So the last question I want to ask each of you is, do you have an example of work that your own organization has done or is doing that you feel proud of, where you've been able to reduce your environmental footprint? And if not, is there kind of an aspirational organization that you look to that you think is doing a good job in terms of decreasing their environmental footprint? Let's start with you, Geneva.
Yeah, we are very thoughtful, not because we want to feel proud, but I am personally very proud of our teams for their thoughtfulness. And one thing that comes to mind is thinking, especially for Matter, thinking about how we are thoughtful about those that we work with, particularly think of early stage companies or startups or diverse suppliers. And very, very proud that we set some concrete, measurable goals that are tied to, how people manage their business objectives, right? This is directly tied to what we do and the success of the individual people that do the work. And we've made some really key investments in, call it more non-traditional spaces in which we play. I think a good example of that is through some of our venture capital investments that really does bring in ideas of health equity and ESG, and one of my favorites, because I did this work, is really thought about how we invested in a company called MD Live that's now part of our portfolio, but started as a company that we invested in through venture capital investments, and that is a provider of virtual care, and we've been able to be thoughtful about how just being able to use that broadens accessibility, but also lessens the need for someone to, hop in a car or take public transit for something that could be relatively simple. It both helps people who may not have as much access to care, or it may be hard to access a doctor or a physician because that might require to take time off from work that they can't do, right? There are a variety of reasons where someone may have a headache and say, I have other things to do. I'm not going to go get checked out. But to be able to make it easier and simpler is really helpful. And I'm proud of that. I'm proud of some of the work we've done online where people can actually go to, My Cigna, which is our dashboard, and they can search by geography, by language preferences. They can really get care that's customized and personalized to that individual. So they're not wasting time searching and searching. But again, they have broader options. So they're not wasting money or time or resources, really precious resources, trying to get to access care in the way that they used to when we're just our teams are allowing our workers as well as our clients and our customers to be more agile in that way, and it has such a good impact on the environment because now we can actually measure by making these changes. These are trackable, measurable, quantitative ways that we can show that we've made an impact in reducing some of our footprint.
Yeah, I love the opportunity to brag on some of our hospitals within the district. I would, Rush, we've heard about all the good work that they're doing. I would add to that, they have bike ambassadors. So we have a bike and pedestrian study going on now in the district because we want to make that much more accessible for our community, and their ambassadors have been a big part of that program. But I also have to read off Jesse Brown VA. So they started Project Catch. That's capturing anesthetics towards climate health. So much to your point, they're very focused on that as well. And did you know, right? Because they're a neighbor, and how closely are the hospitals working together on some of those things that we know we should all have in common. I would also say UI Health Specialty Care Building, that was completed in the fall of 22. Not inexpensive to build a LEED gold building, but they determined that was important for them, and so that's what they did. And the IMD may be oversimplified, but working with those people who share your passion like Morton Arboretum, they gave us trees to plant. And we worked with our local high school students as volunteers to help us put those trees in the ground. And the last one I'd mention, and because I think it's worth mentioning the disruptors that happen and the power that can give us, is COVID. And maybe the silver lining of COVID with telehealth and helping us to realize that we can connect with our patients in a different way that doesn't require them to travel, doesn't require them to park, and really makes access simplified for them. So, those are some of the few maybe pride points that I have for the district, but there's so much more we could be doing.
It's terrific. Thank you.
Just one slide. Could you put that last slide I've got there? That's it. Leave that one. No, go back. The one you just had. So I've mostly been talking about healthcare without harm, and it's certainly something I'm proud of, from that bar in Windsor in '94 to the current time in 80 countries around the world, and impacting on the UN supply chain and a whole variety of things. This past year, 2021, in conjunction with a couple of other groups, it has put out this climate change cookbook, really, which is globally appropriate and very specific. And so that if any of your institutions are interested in how to get started, or where is something that you might not have thought about, I refer you to that monograph, and it's on the web, free.
Terrific. Thank you. Let's go to questions now that came from the audience, and the one that has the most hits is about biking. I think it's a question about keeping people healthy, patients healthy, and visitors healthy. They want to bike, walk, or roll to get to their destination. How do we reduce cars and trucks on the road? Yeah, that's a tough question. Anybody have any thoughts on that?
I mentioned it. We do have the bike and pedestrian safety plan. The study is just finalizing, but it is about making it easy, right? Like making it easy for you to park your bike, making it easy for you to service your bike, making it easy for you to understand, how do I put my bike on the front of a bus, right? How do I, there's collapsible bikes now that you can put onto the train. So really, I think it starts with education. I think we have a real opportunity to do more to educate around biking. I biked to Douglas Park just to see how easy that would be, and it was a lot easier than I thought. It's also about working with the city, working with CDOT to make our streets and roads feel safe for biking and walking and rolling. So I think that, and more now than ever, I came from ambulatory, and when I started in ambulatory in the mid-90s, you thought about access and accessibility, but it wasn't the primary type of patient. And now in outpatient, you see more wheelchairs, more walkers, more alternative means of accessing your outpatient care, because care can be done in the outpatient setting now more than it could long ago. And so I think for that reason, we really have to pay close attention. We have the mayor's office with people with disabilities in the district, and we lean on them as well to tell us, what is it that your population needs?
Yeah, and to add to that, I also think that is a really good example of preventative measures that you could take so that you don't always end up, in a hospital. Something like biking is part of a path to overall wellness and health. And taking a little bit of shift from my day-to-day job, but I received an Eisenhower Fellowship last year that took me to South Africa and Jordan, and I was studying whole person health for children, particularly children in underserved communities. And right outside of Cape Town, spent a lot of time with a biking group for young women, teenagers, 13 to about 16, and part of why they chose bicycles is because they said, like, we're trying to create more of a biking culture. There's limitations to having to depend on a car, but also, you know, cars have such an impact on our earth that doesn't align with many of our beliefs. So instead, we're trying to teach our children at a very young age, this is a mode of transportation that has so many additional benefits. So by the time they become our age, it's a habit for them. You know, there aren't those same barriers that you have to unpack, which I thought was, they were having really great impacts on, you know, showing the children, like, this is the way of the future. And then the great thing about that is they also took that back to their community. So what they saw is, like, you know, those young women were biking, and then their parents were getting on bikes, and then their siblings were getting on bikes. And so it transformed a whole town, because now, well, you know, you didn't have to worry so much about things like cars and parking and public transportation, and you just needed the ability to get on a bike, and you could even rent the bikes, like, for very cheap, and you just get up and go in a way that they weren't able to do before. And that cultural change made such a big impact. And I think probably 20 years from now, if I have the pleasure of going back there, I will be able to see how that impact was exponentially greater than it was even last year.
Amen.
Amen. Peter, what healthcare environmental innovations are you most excited about? Are there innovations to reduce medical waste?
Yes, but we have to divide this geographically, if you will.
Sure.
In this country, the first thing we began to work on in healthcare without harm in the late 80s, even before it was formed, was the question of incineration of medical waste. And that was the first time we confronted our preconceived notions. For a physician, it was wonderful to have an incinerator in the hospital. You took all of this stuff with blood and this and that on it, and you put it in the incinerator, and it burned up, and it came out gray, much less, about a quarter of the amount. And how could that infect anybody? Turned out that wasn't the right way to go about it, because we're burning all of these polyaromatic hydrocarbons, and, or rather the PVC plastics, polyvinyl chloride plastics, creating dioxins as we did it. So the first, and that was an issue, that was an environmental justice issue, because so many of these medical centers were smack dab in the middle of low-income and minority communities, and people in the communities were arguing and upset about what was coming out of the stacks, and they were quite rightly so. It turned out that after 10 years or so, you really couldn't find any U.S. hospitals that have an internal incinerator anymore. Not as good a story as we hoped, because a bunch of it was sent to a central area, but still very good. And Illinois was a laggard in it. Only about 10 hospitals still had internal incinerators, but they're all gone now. So it's an old story, but it's a nice story because it's effective, it worked, it's in conjunction with local communities, and it improved the local environment, as well as, due to dioxin, which spreads all around the world, improve that as well.
Yeah. Allison, have any innovations you're excited about?
I mean, sitting outside of the healthcare organizations proper, you know, taking a look in terms of what I see them doing. I mean, I think just the fact that many of our healthcare organizations are pledging net zero by 2050, you know, that excites me, because again, leadership is getting behind it. Now, what we want to do is make sure we're giving them, you know, steps or assistance or community support or a voice or a story that helps to move that forward. But I would have to say, I feel like that's something we can anchor on and start to have a conversation around that prior to those pledges would be hard to do.
Great. Anything else, Geneva? Okay.
Amen.
Amen again. Lots of prayers. Here's another question. What messages or response would you offer to individuals who believe that these efforts to address health inequities and climate change are merely a byproduct of the capitalist system in the United States, and without that, the entire system would collapse? In 30 seconds or less, how do we make our economy circular?
Well, you can always hope that these byproducts would disappear, and if that means the system's not making any profits, I guess we got to rethink where we're going and why, and who the system ought to be directed to supporting as a reason for existence. How's that?
Anyone else want to take a stab at it? No.
The
younger generation, let's move on.
I have to add a short thing.
Okay.
Unfortunately, now having done this all around the world and doing this in a number of countries with universal health care, government-provided health care, et cetera, there's no paradigm on these issues either. And so much of what we said turns out to be applicable whether you have a private sector healthcare system or whether it's part of the global governmental budget. You need special attention to this and special attention to avoiding the costs.
Okay, here's another question. The younger generations value sustainability. How do we gain support of older generations or current leaders in healthcare to get on board?
I mean, I do think it comes back to incentives. You know, financial incentives, quality incentives, I think those are the types of things that leaders will get behind, right, and make the change around. So, you know, how do you tie it, you know, quality indicators continue to change over time. The work of hospitals with the Joint Commission continues to change over time, and leaders pay attention to that. So I think it has to be baked in to what we ascribe to in healthcare as the gold seal of how work gets done. It needs to become a part of our quality standard in terms of how we work.
I would also say, too, that, you know, sometimes we quickly make the assumption that there is a bright line between generations that I think is too simple of a way to explain, and it isn't always inclusive. And sometimes when we ask, even in those questions, right, we shouldn't be dismissive of someone who might fall in the category of an older generation, because they're coming from a place where, you know, what they're thinking is often still valid. Now, you know, maybe we've realized that as a society, younger people may understand sustainability in a different way because they've grown up with it. They've always known that climate change was an issue in a way that, you know, if you're decades older, you didn't hear about climate change during your formative years. But there are some things where it would show that generations are still aligned. If you think of something like legacy, I think that often resonates very well with people who may be of what we might call an older generation, but thinking about how what I do today impacts my children or my grandchildren. We've been thinking about that for millennia, right? Like, that is not a new idea, and I think that often will bring people together, because in that way, if you think about it, we're saying a similar thing. Like, both, whether you're 20 or you're 80, you're thinking about what you will leave behind to your children, your grandchildren, your nieces, your nephew, anyone that will be here when you are long gone. And that is something that can connect us as human beings. So the action items might be slightly different, but if we think about it, we're starting with some of the same core values. And sometimes I think we sort of jump to the end without starting at the beginning, unpacking what we're really saying. And what we're really saying is, at our core, like, this is the value, which I think often there's a lot of value that will bring us together because they're probably more similar than they are different.
Thank you. Peter, any thoughts?
Well, much to my chagrin, all of these older people in the leadership of healthcare have become younger to me. So I didn't try to do this, but it happened. So I don't know what that means anymore.
Well, that's our last question, and I just want to thank the panelists for bringing your thoughts and opening it up to the audience here. I think it was a lively discussion. I really appreciate your input. So a round of applause for our panelists, please.
Thank you very much. Yes. It was great. And I think what was really nice, it was inspiring to see that there are solutions happening, there are roadmaps that are possible, and there's creative thinkers making those changes, and there's leaders emerging that care about this, right? And so our challenge then is, wherever we are in that health system, I took away is know the decision-making structure, know the committees and councils to get on, know how to get, position yourselves within those pathways. Think about ways it can be baked in as part of whether that's a personal evaluation you have to do every year, whether that's the leader's evaluation, or whether that's a quality indicator. How do you bake it in? We love in healthcare to say what gets measured gets managed. So what gets evaluated gets managed as well. I think, really thinking also around that's what's neat to see with the roadmap, that you can align it with the financial incentives, and it can be cost savings. And so there's evidence that just needs to be leveraged. And so I think I walked away with more hope. I think Andy was mentioning, we were talking about, any of you that likes diffusion of innovation, how many of you have heard the tipping point from Malcolm Gladwell, right? It's essentially diffusion of innovation theory. And they talk about when you get to this 25, 26%, it's a tipping point. No longer are there innovators who are coming up with the idea and trying out. It now becomes part of something that the majority finds pragmatic, practical. They can do it because they've seen it. And maybe we are at that tipping point of having those kind of leading health systems, the evidence, and our job is how do we spread that word so that evidence just doesn't stay within a Chicago environment or stay within a Boston environment or whatever environment you're dealing with. So I just want to say thank you. I get the pleasure of closing up. I know we have half an hour here. I'm going to try and go faster. I know it's been a long day. We hope that today would be a day about, as the sign behind me says, connect and create, that it would be an opportunity to convene conversations and listen to one another and provide a space to reflect on where do we go next. And that's what I wanted to use my time for, is a bit of that reflection and how we might capture your energy while you're here. So I have too many things in my hand. Let me go to there. So we ended with reducing the carbon footprint, but it's really nested within thinking about health inequities more at large, and we're nested within communities, and that's the systems in which we operate. So what I'd like to do, and I have not memorized it by now, what is it, Matter QA, wait, what is it, social Q, yeah, okay. matter.socialqa.com. If you have not opened your phone or digital device, please do. We'd love to enter in your reflections, your reactions. If you could put a number next to it, you don't have to, just to help us know one. What did you take away from this as your energy? Whether that's excitement, concern, happiness, surprise, can be one word. We're just trying to get a barometer of the room. Where do you see some immediate opportunities? I was kind of leading a few breadcrumbs along the way, but what did you take away? What do you think are the critical jobs to be done? Where do you see the most urgent pains or gaps that need to be addressed? And where do you see opportunity for gains? That we can turn this in, I think our last panel talked about a passion project. That's a social gain. How do we turn this into something positive to do? And what action do you see that we should mobilize next? So I'm just going to give you all a few minutes just to do that. I have to find the iPad that you had. You have, okay. We might just share out a little bit. No pressure. We will send you a formal evaluation too, so. I'm registering 4 people online, so hopefully there's more than 4 of you that are just inputting. So some of the things folks are writing is that there's hope, that we are having the conversations, that we're making visible and elevating the agenda, as we like to say. That there's energy in the room for social gains, but also concern that time is not on our side. You know, and as people are reflecting, sometimes we knew in public health that we should prepare for pandemics. If you've ever had any basic 101 class in public health, you knew about the 1918 flu epidemic. You knew about H1N1. You knew about all of the various, pandemics that have come through. Major flu pandemic in 1956 as well, right? But it's not until it's front and center in front of you that the urgency to act suddenly becomes what they like to say a pants on fire problem. And, gosh, I hope that we can be a little bit more foresightful in this and that it doesn't become the problem that is so front and center and we've lost the opportunity to act. Because who was it that said it? The planet will roll on. Yeah, I mean, the dinosaurs aren't here anymore, but the planet still is, right? So Mother Earth will be here. Anything else? I'm just kind of flowing through here. Yes. I mean, I'm seeing energy. That's what we hope, and an encouragement. So maybe I'll leave on that thought. And Matt, do you want to just say where we're going next a little bit? Or do you want me to cover it? Well, sure, yes, you or me? Okay. Because this is a quest, and as I said, the quest doesn't get solved in one day, unless you're playing a certain kind of quest on a game in which you get to the castle.
Thank you, Dean Morato. For those who I haven't met, my name is Matt Anderson. I'm the Associate Professor and Chair of Healthcare Administration in the Parkinson School. I was a small piece of the team that was helping to organize today's festivities. Before we answer that question of where we're going, wanted to thank a few people for making today possible. It certainly doesn't happen in isolation. It takes a village to put something like this together. I think earlier this morning, the Parkinson Innovation Fund was mentioned. Our sincere appreciation and thanks goes out to the generosity of Bob and Betty Parkinson for making this all possible. I want to make sure that I thank our Loyola and Matter teams that went through countless hours of coordinating and planning to put this together, specifically Mike Bloom, Merle Thomas, Jennifer Sloan at Loyola, and Sam Stavig, Casey Sheridan, and Olivia Phillips at Matter for making today possible. Also want to give a huge thanks to all of our speakers, panelists, and moderators, with special thanks to President Mark Reed from Loyola, our keynote, Dr. Jalon White-Newsome, and our fearless leader in Parkinson and today's MC, Dr. Elaine Morato. So I want to give her a round of applause. If you enjoyed what you heard today and you would like more opportunities to interact, we have several upcoming events that are located in your electronic communications. Salon 24 is coming up on March 12th. That will be here at Matter. The Loyola Stands Against Gun Violence Community Advocacy and Violence Prevention Summit will be on April 3rd. Dean Morato had mentioned that you'll be getting an evaluation of today's activities, so please provide your feedback to us. Let us know if you enjoyed your experience, the things that went well, the things that you'd like to hear more about in future health equity quests, and we will definitely take that into consideration. As to where we're going from here, we'll be working to publish and write a white paper summarizing today's activities to make sure that the information collected today doesn't get lost in the ether and sit alone somewhere. This is an important first step in improving sustainability and health equity across the healthcare spectrum. The take-home messages, I think, were we need to be disruptors in this space. Dr. Orris said we have a responsibility to do no harm, and health systems have a responsibility to their patients beyond just the four walls of the hospital. We need to also have empathy for those not with us yet. Dr. Garman had a slide showing, just in broad terms, the population of individuals not yet born far outweighs the people who have existed in history. And so it's not just for us today. Any of us who have kids at home, grandchildren, nieces, nephews, young people we care about, it's not just about us, it's about them. It's about the future. And Geneva had a lot of really interesting and salient comments about the idea of legacy. And this is about what we leave behind. So again, this is the first step in advancing the conversation in this really important work, but we need to act now. So not just continuing to talk, but collaborating, coming together across industries to find pragmatic, real solutions to make an impact, to reduce healthcare's carbon footprint, and to improve sustainability, to improve health equity across the world for at least the next million years. Dr. Murado, is there anything else that you'd like to say to close us out?
Thank you to everyone that is online still with us and the tens of people that are here in the room with us. I think we all get energy and are inspired by you and each other. And I'll just close with this. At Jesuit Catholic institutions, we often quote things that St. Ignatius said. And so I don't think he actually said it, but it's attributed to him. And it's this expression that says, go out and set the world on fire. And that means take your not literally. In today's topic on climate change, that's probably not a great quote as St. Ignatius. But no, it's to take your heart and your passion and to go out and do something for social justice. But to know that we are each one spark at a time. And so we hope today gave a bit of a spark so that as we all continue to work together to address this important problem, we're contributing to the global effort. So thank you.